So, good morning, good afternoon, everybody. This is a very special moment. And I just want to start the meeting and wish you all heartily welcome. I think we will have some practical notes coming out from Alena or Jack. Are we going to do that first? Alena or Jack?
We will go over that a little bit later.
Okay, that is super. So I think without any further ado, I would like to get us started. So first of all, thank you so much for responding to the call for interest to be, I would say, the pilot group for one of the most important NCDs among the four. Why is it so important? We'll learn a lot about that today. You know already, this is the one disease that is now increasing in premature mortality. We have seen people suffering during COVID, and we know that there is 100 years since the discovery of insulin. So it's a really good time to do something, and you are invited to co-create with the WHO to see how we can get action and dreams translated into reality. So without further ado, I would like to introduce the day one co-chairs. So Bruno Hellman, our Views, Our Voices Advisory Committee, International Diabetes Federation, Brazil, and also Heather Koga, IDF Blue Circle Voices, Zimbabwe. The floor is yours, their co-chairs. Please go ahead.
Thank you very much, Dr. Banti. I would like to take this opportunity to acknowledge the GCM, the NCD department about the importance of this moment. It's really important that we gather our community and bring the different voices and the different views and the different perspectives in order to raise awareness and to enhance the meaningful involvement of people living with diabetes. If there's something that diabetes taught me, is to be grateful. And I couldn't start the day without acknowledging and thanking all the commitment and efforts that all the diabetes community have taken along the years. If I have the privilege and the honor to be here today and to have the really challenge and I must say almost impossible position to speak on behalf of a very diverse community as ours, is because we had the effort and we have the passion of so many great advocates that have been dedicating their whole life for this cause. So now I'd like to pass the word to my great colleague, Ms. Heather, that will be leading this or co-chairing this morning or this afternoon, depending where you are with us. Heather, please.
Thank you very much, Bruno. I would like to thank everyone who has made it to this meeting. And I am hopeful that there will be a lot of sharing of our lived experiences and also learning from each other about this condition and how best we can advocate for the improvement of the quality of life of people living with diabetes. So for a start, I'm going to introduce our next speaker, who is going to be Dr. Tara Collins. And she is going to be speaking. There is another speaker who was supposed to be here. So she's going to be speaking on behalf of another colleague, Dr. Slevana. So for now, over to you, Dr. Tara.
Well, thank you very much, Madam Chair. Can you hear me? Yes. I'm very happy today. First of all, good afternoon and welcome all. At the last minute, I was informed that I need to step in for Dr. Svetlana Axelrod, and I'm really happy to do this. Dr. Axelrod is the director of the Global NCD platform, where GCM is housed along with the UN Interagency Task Force. And these are two very strong mandates. I'm sure our participants are well aware of that. With a mandate to accelerate action across the sectors and stakeholders. And in collaboration today with the NCD department, I see Dr. Bente Mikkelsen. This is truly a pleasure to work with her again. And so today's meeting will be building on the very successful event of Global Coordination Mechanism back in December, when we held a 3-day consultation with people who have lived experiences of non-communicable diseases. And today we're holding the first consultation specifically with people living with diabetes. And again, I want to commend Bente on initiating this Global Diabetes Compact. We're very happy to be working with you on this, Bente. And we think that this is a very important event. And why this is so important, and as I was getting ready for this call, I looked again through our materials and our past work, and it is really staggering to see that rise of prevalence of diabetes, particularly type 2 diabetes as a clinical problem, is very well documented. But there is so much less attention paid to the potential for the rising global diabetes problem from the perspective of widening health inequalities and the need for solutions to address them. Because 75% of these cases occur in low and middle income countries where the impact of diabetes is particularly severe, as the disease is chronic. As we all know, it's very expensive to treat and tends to affect economically active people. The economic cost of dealing with the consequences of diabetes is not only a threat to health systems, but is a far broader economic and social problem and a threat to future long-term sustainable development. And this complex problem requires complex multi-sectoral and multi-stakeholder solutions with the active involvement of people who are directly affected and who have firsthand knowledge, experience, and understanding of what would work and under what circumstances. So this consultation, that's why it's so critical to inform the work of the Global Coordination Mechanism and its partners to advocate for strong, equitable, and person-centered health systems with a strong participation of communities to address NCDs at global, regional, and local levels. I'm delighted to join this meeting, and I wish all of us very productive and successful 3 days ahead. Thank you so much. Over to you.
Thank you very much, Thea. I must say that in December 2019, it feels ages ago, when we had the chance to meet during the high-level meeting, the informal high-level meeting for NCDs and mental health. I made a request to see meaningful involvement, taking action, and being materialized in concrete and effective mechanisms inside WHO. So I'm really thankful that you, Guy, and the whole team heard us, and then you're giving us this opportunity. I'm sure this is a game-changing experience and a game-changing opportunity on NCDs, and I must say that my hopes are really high on this. So further ado, I would like to call our next speaker, Francesco Branca, who is the Director of Nutrition and Food Safety for WHO. Please, Francesco.
Thank you very much. Good morning, and I'd like to join Bente and Thea in welcoming you all to this consultation to design the WHO Global Diabetes Compact. Obesity may account for 80 to 85% of the risk of developing type 2 diabetes. Addressing obesity needs therefore to be an integral part of the strategy to fight diabetes. Worldwide, obesity has nearly tripled since 1975. As of 2016, more than 650 million adults were obese, or about 13% of all adults globally. The prevalence of obesity for children more than doubled over the last 2 decades. We are nowhere close to achieving the multiple targets established for obesity in all age groups by the World Health Assembly. Addressing obesity requires both prevention and management. Preventing obesity starts with good maternal nutrition and managing weight gain in pregnancy. This requires better antenatal care. It then follows with good infant and young child nutrition through promotion, protection, and support of breastfeeding, continuing until the age of 2 years and beyond, and more nutritious food for children. This requires better prepared health workers and confronting the aggressive marketing of breast milk substitutes. This also requires action to reduce the sugar content in baby foods. Prevention requires a food environment conducive of healthy choices, using pricing tools such as taxes and subsidies, and regulating the marketing of food to children. It requires nutrition labeling of packaged food that could be understood also by young children. Prevention requires active societies, active environments, and active systems so that we can live active lives starting from early years. But our health systems need to take adequate care of people living with obesity. Unfortunately, this only happens in a few high-income countries. This is why WHO is now developing locally adaptable, science-informed recommendation for care of children and adolescents with obesity and for young children at risk, delivered at the primary healthcare level. This will be a first step to better equip primary healthcare services to deal with obesity. WHO is working with partners such as UNICEF, the Food and Agriculture Organization, the World Obesity Federation, the NCD Alliance, the World Cancer Research Fund, and the Bloomberg Philanthropies to propel global initiatives to prevent and control obesity. We believe this will be a critical contribution to the success of the Diabetes Compact, and we'll be working with you to make it happen. Thank you.
Thank you very much for those insights, Francesco. At this point, we would like to call upon Rogerio Gaspar, the Director, Regulation and Pre-Qualification at the WHO. Over to you, Rogerio.
Thank you very much. First of all, let me thank Bent Mikkelsen and her team for this kind invitation, and already apologizing for not being able to be present during the entire duration of the consultation. But just to make you aware that we are deeply interested in the conclusions of this consultation. Let me say why a regulatory department is interested in this subject. First of all, we have to recognize that regulatory systems are an essential component of the health systems, not only because it was recognized a long time ago by World Health Assembly Resolution 6720, but also because this is part of a number of initiatives at the regional and global level during the years, and some reports, more recent reports from Lancet Commissions, National Academy of Sciences, and others have visited again the problem. The essential thing to remember is that functional regulatory systems working in a cooperative form under principles of reliance are critical to allow faster access to availability of affordable, quality-assured health products, including medicinal products and medical devices. Strengthening national regulatory authorities' capacities and organizational frame is critical to that endeavor, and WHO is an essential part of the process in several regions and countries. The second aspect to remember is that the facilitation of affordable access of health products by people living with diabetes can be done through, from my side, in 3 different streams. The first one is looking at the issues dealing with the pre-qualification of insulin and monitoring devices. One of the critical issues has been the lack of mobilization for pre-qualification of affordable insulin and affordable administration devices, including insulin administration pens with interchangeable cartridges. Monitoring devices can cost even more than medicinal products, and there's an evident lack of stimulating this side of an affordable health goods market. A second issue on this affordability and access is also the engagement that is needed from the patients and patient representative organizations with the regulators. One of the important issues is the participation of patients and patient representatives at all levels of the regulatory system, as it is done since 20 years at European Medicines Agency and other agencies, but still lacking in an immense part of the world. And when we are addressing these issues with the regulatory authorities, we are bringing this together with our assessment. We need to expand from the current situation, moving in the direction that others started a long time ago. And just to remember that the patient's participation at the Committee of Orphan Medicinal Products at the European Medicines Agency started already 21 years ago. A third component is to move forward in a cooperative way. And just to remember that some of the issues that are blocking the way for more affordable health products in this area could be solved or should be solved by a cooperative interaction between patient and patient representative organizations, manufacturers, regulators, and R&D sector. This was done in other areas, and just to remember the important role of Innovative Medicines Initiative, which was a public-private partnership in the European continent for the development of an Ebola vaccine. Also to remember the initiative that was very important for the development of a vaccine to meningitis, MEN-AfriVac, also a cooperative process. More recently, the Act A has showed an important role in the response to COVID-19. And again, it's a partnership between different organizations and entities. So my final question for this group and for the next 3 days of discussion, what about diabetes? We need to stimulate companies' engagement in pre-qualification for easier availability of affordable health goods. So there's here a room for promoting platforms like MEN-AfriVac and others. This is my question to this group, and I will be listening carefully the time I'll be here and looking at the reports from the consultation to engage thereafter. Thank you very much to all.
Thank you very much, Rogerio. And thanks, Francesco and Thea, for the really thoughtful and interesting insights. Just a few reflections, and just to make sure this is my personal thought about it. First, regarding what Francesco brought about the high relation, and I would say almost the simply relation between type 2 diabetes and obesity. It's fundamental that we try as a NCD community to break silos and make a strategic partnership with other NCDs in order to move forward. But also we must remember that diabetes, especially type 1 diabetes, have these particularities that I would say that as far as I know, there's no other chronic condition such as ours that require such a specific type of care. Also, I believe it's important, and I would like to reinforce Francesco's words, that usually when we talk about NCDs, we usually talk about prevention, but we cannot forget the millions of people who already live with both type 1 and type 2 diabetes. So when advocating for diabetes care and management, and also prevention, we cannot forget those that already have the condition. I just slightly correction, and I apologize in advance, Rogerio. I just must say that I understand when you say when you use the word patient, but be sure that in our community, especially the diabetes community, if there's something that we are not, are patients. We are impatient for change. We are impatient for stop people losing their lives for a condition that has treatment for almost 100 years now. So I totally understand your point when you use the word patient, but just to make up our point and to enhance our movement, and this is something supported by NCD Alliance, that we are impatient, we are eager to change, and we won't take and wait any longer to see a switch in the conversation. Now I would just like to pass the mic to Heather and see if she has any thought that she would like to share with us.
Thank you very much, Bruno. Yes, I think that was a very interesting perspective. I really liked what Dr. Francesco shared about how childhood obesity begins even with the mother being pregnant, and also the kinds of baby foods that are on the market. So I think there's really a lot of work that we need to do. And as you said, the diabetes community is very much eager and willing to find solutions. This is a very difficult disease. It is very difficult to manage. It is also very costly to manage. So I am really happy about all these perspectives coming out. And I hope everyone is learning and will come out with something from this meeting. Thank you very much. Bruno, I think you will introduce the next speaker.
Yes, so now it's my great pleasure to call Alena Metzke from the NCD department and Jack Fisher from the GCM NCD WHO, who are the brains and hands behind the scenes, making sure that these 3 days go smoothly. Just regarding some IT notes before passing the mic to them, that I would just like to reinforce that if you have any IT issues, please contact either Jack or Alena. That will be more than happy to provide you assistance. So Alena, Jack, over to you.
Thank you very much, Bruno, and thank you, Heather, for those kind remarks. I should also counter that. I think that whilst it has been a huge effort from WHO's side to put this consultation together, there's also been a great consultative process with those with lived experience to co-create the agenda. And that's really important to ensure that hopefully you can see over the next 3 days that there's lived experience integrated, both as co-chairs, as speakers, as facilitators. And of course, there's a huge amount of brains and expertise and experiences with all attendees as well. So that for us is the real richness of the next 3 days. And I think we are very humbled to have this really interactive and productive 3 days ahead, and also to bring such a diverse and passionate group together. I was part of the team who was organizing or co-organizing the December consultation. And it was great now to reconnect with that community that we established in December and feed this into a very exciting new initiative, a new global initiative, which will be launched next month. So I just want to reinforce one aspect that we have been including as part of our briefings to all of those that we spoke to last week. And is that even though this is a WHO consultation, we really want to ensure that the lived experience is driving the narrative and driving the discussions across the 3 days. So we very much welcome you to engage in the participatory processes that we've set up. We want you to be very interactive in the group chats. I haven't had a chance to look yet, but I can see it's really very active already, at least by the number of notifications. And of course, the breakout sessions. We have 4 breakout sessions over the 3 days. And this is where we will very much build upon the discussions that we have during the plenary as well. So before I introduce our first icebreaker and our first Slido, I'd like to pass to Elena to introduce herself and also the survey results. Elena, over to you.
Great. Hi, everyone. It's such a pleasure to be with you. I'm, as Jack, really humbled, both for having been part of the process to put this meeting together. It's been absolutely fascinating to work with many of you on the program, on the presentations, and really making sure that this is reflective not only of what we at WHO think of in terms of engaging people living with diabetes under the Global Diabetes Compact, but really also reflecting your inputs and views and really rich perspectives. First of all, I want to just encourage everyone to feel free to stand like I am doing, for example. It's a long meeting, so if you're sitting down and at some point get tired, feel free to move around. It's an informal meeting. You should be feeling well and clear to make it through the next 3.5 hours. We have a really packed program, so please take care of yourselves. And now I wanted to give you a short overview of who we have in the room. As you'll see, many of you will have your cameras on. I encourage you to have your cameras on for as much of the time as you feel comfortable. It's really nice to see everyone's faces. Of course, I understand that sometimes you need to switch off the video, but I feel like it creates a really nice atmosphere as we can be together here in the room. So who do we have in the room? We currently have 114 participants. We have 138 participants signed up. So people will come in and out throughout the 3 days. And those 138 participants are from 58 countries around the world. You can see here on the slide the regional split. We have all regions represented, which we're really excited about. Next slide. All right, we have a very young group around the table, as you can see here. We have a lot of the largest segment of our participants are between the ages of 25 to 35. And then we have a couple people just between 18 and 24, and another large chunk of people between 35 and 44. So really a lot of interest from young people, but also representation from all age groups. In terms of, this is really interesting to me, we have a lot of women around the table, and we actually struggled, and this is the first time in my life that I struggled making sure that we have enough men as speakers on the program. So a different kind of struggle in the setup of this meeting this time. Next slide. All right, so in terms of the representation of people living with diabetes, so 70% of the people in the room live with diabetes, with just 1% indicating that they don't know, and 4% preferring not to share. We have a greater representation of people living with type 1, which isn't perhaps all that surprising, but we have a good 20% that live with type 2. And again, here 14% prefer to not share that information. Next slide. Interestingly, so not everyone living with diabetes also identifies or seems to identify as a person living with NCDs, which I personally, again, don't find all that surprising, given that NCDs is sort of an umbrella term, and not everyone might identify as a person living with an NCD, even if diabetes is classified as such. We have about 68% of people that, we have about 18% of people that identify as persons living with a disability. Next slide. All right, and then a large majority of us are working or engaging in the topic of diabetes, and almost equally great number of us are working on the topic of NCDs. All right, so that's it from me. I'll hand over to Jack for the next questions.
Thanks, Elena. And just to mention as well, I'm sure everyone here has participated in a number of surveys over the last couple of weeks, as given by us. And of course, we are only providing a very small snapshot today, and we will definitely include all that data in the post-consultation report. And of course, the consultation report is not just the only output of this consultation, but also really trying to identify those key engagement opportunities within the Global Diabetes Compact as well. So we now go on to our first Slido. Slido is a excuse me, an interactive polling tool that we'll be using across the 3 days. Mahim, if you could possibly go back one slide, that'd be great. Thank you. And we have 2 questions which are going to pop up onto your devices soon. One will be, which stakeholder or group best describes you? And you can select all that apply. And the second is, do you have a lived experience of diabetes? So if we go to the next slide, you'll see a QR code which will pop up. And you feel free to use your camera, literally just open up your camera like you're taking a picture and hover that over the QR code, and then a little URL should pop up. And if you click on that, it should take you to a little polling screen. And with a little bit of luck, I should then be able to show you what that looks like in real time. There we go. If I click here. Oh, here we go. So we can see that. So this is my first time using this on 2 screens as well. So we have a lot of lived experience advocates, 83%, a very healthy portion of NGO representation within the room. I'm very, very happy to see that we have a good portion of our WHO and UN colleagues representing, and across the various agencies we have within the UN family. We also have some entrepreneurs in the room as well. And we have 38. I'm sure there's quite a few more people in the room who are still yet to answer.
If you can't manage the QR code, you simply have to go to slido.com and then slot in the code WHO people living with diabetes that I just put in the meeting chat. It's fairly easy. There's a window there on slido.com where you add that code, and then you will immediately be asked to complete those questions.
Fantastic. Thank you so much, Elena. So I think we have over half the room who's already participated in the first Slido. Just to be conscious of time, don't worry, there's plenty more Slidos remaining for the rest of the 3 days. So maybe we'll go on to our second question, which is, do you have a lived experience of diabetes? So 57 people have already responded to this. Don't worry, if you still to respond, you still have time. And 61% say yes. I believe the surveys that we had, which was a slightly bigger group, I think it was close to the 70% mark, if my memory serves me correct. So I think that hopefully gives a bit of a, not only an introduction to Slido, but also a bit of an additional feel to who's in the room as we start this this journey over the next 3 days. Super. So you'll be very well versed by the end of Thursday within the Slido technology. And of course, with new technology, we always have a group photo normally in traditional in-person meetings. But of course, in the world of Zoomtopia, we have to all put on our cameras. So we very much welcome you to, if you wish to, put on your camera. Very welcome to smile as well. And we'll take a quick group photo. So Mahim, if I could ask you to take off your screen, and we can see hopefully lots of happy faces across the world. Super. I have the multitask now of trying to look happy and press buttons. Super.
Hi, everyone.
Fantastic. Hello, Mark. Good to see you. Wow, it's a great positive energy. Oh, actually, I think there's some more people who just put on their cameras. I don't want to miss you out. There we go. Super. Thank you so much. And I think at this point, I might pass back to the co-chairs. Thank you.
Thank you very much, Jack, Alina. It's great to see some diversity, and especially even though we should improve, I must say that 20% of people living with type 2 diabetes is quite relevant, and we as type 1 diabetes community need to ensure to include and make the room appropriate for those living with type 2 diabetes. Just before passing the mic to Dr. Banti, I would just like Jack and Alina to clarify Patrick Nagasa question, the meaning of lived experience of diabetes. So if you could please explain to everyone the WHO definition, that would be great.
Jack, I'll leave that question with you.
Sorry, so the question is, what is the meaning of lived experience of diabetes?
Yes.
Well, I think it's quite an interesting question, and I'm a little bit hesitant to answer it specifically, because I suppose, of course, you know, if an individual has experience of suffering from type 1 or type 2 diabetes, then they will have a lived experience. But I don't think there's necessarily one definition of a lived experience, considering the variety of individuals who may have a lived experience. So I wouldn't say that there's necessarily a WHO definition from our side, but maybe that could be an interesting discussion to open up to the rest of the group in the group chat and also the breakout discussions.
Perfect, Jack. So
I think
now it's
Guy, you have
Please.
your hands up.
Thank you. Yes, thank you, co-chairs Bruno. And as I join you the first time, welcome to everybody. I'll come back a little later and provide some overview of other activities. But I wanted to come in on this because this is a really important question. And as we were leading the consultation in December, we had very in-depth discussions on meaningful engagement and what meaningful engagement meant for the community at that moment. And I think we landed on something very, very interesting, which is actually we started defining it as an intersectionality of lived experiences, not only within a particular NCD or programmatic area or disease area, but really understanding how an individual can provide his perspectives, insights across the many layers of experiences, political, environmental, social, economic, family, community experiences. So ultimately, we are looking at a person with a layered experience, intersection of connections and perspectives and insights, whether he be a family member, a brother, a father, someone living with a disease, how he accesses or difficulties in accessing health services at different levels, his gender, ethnicity, et cetera, et cetera. So I think that is the important, the interesting message here, that the lived experience is not necessarily limited or relevant to a disease. It is a perspective that encompasses the whole personal experience of an individual. In addition to and through the experience of that disease. So I think that will come up in the discussions, and I think that we will end up maybe discussing that in one of the groups, of the intersectionality of the different experiences that make up the value and the expertise and the experience that we're looking for. So I hope we can discuss that later in the discussion. Back to you.
Thank you very much. Just breaking a bit the protocol. I hope that's all right. Johanna, I saw that you have your hand raised, so if you could please really briefly share your perspective.
Sure, sorry, I didn't want to interrupt, but I think actually somebody put this in the chat. I wanted to acknowledge the role of, I don't have lived experience of diabetes, I have lived experience of multiple sclerosis and cancer, but I think family members can very much, because so much of living with diabetes and most NCDs is about navigating systems, about how you modify your life in order to manage the disease in the best ways possible. So much of it does affect also family members, caregivers, others. And I just wanted to acknowledge their role. Thanks.
Thank you. So please, Dr. Bent Mikkelsen, who is the director of the NCD Disease Department. Please, over to you again.
Thank you very much. And it's so encouraging having co-chairs like Bruno and Heather, and also thank you to Alena and Jack. So I would like to start with actually thank you for asking the question, what is lived experience? And I was defining myself as one of those because my best friend over 40 years, I have followed him through ketoacidosis, bone fractures, wrong medication, kidney failures, blindness, kidney transplantation, and all the different things that actually happen to you when you're born with type 1 and doesn't really get the care that you need. So in a sense, I feel also among those with lived experience. So thank you for including us. So if you can give me the first slide, and I have sort of the privilege of being a little bit more lengthy, and I hope you will bear over with me. And I will try to make it clear that, you know, I'm so happy that we are now the first of, I would say, to try to mitigate what hasn't really been the case for NCD, namely to invite people living with diseases, and this time it's diabetes, to the decision-making table, to the full journey, and also to help us to co-create when we have this golden opportunity of actually launching something like the Diabetes Compact. So it is a journey. We are in the beginning. It will last for many years. Nothing is, or many things are not set in stone. At the same time, we also have to respect all the consultations. So I will share this with you. It will be maybe a lot, but we will share it. So the presentation will be with you during these 2-3 days. And the idea is that we need to engage, but engage for what? So in my view, this meeting is not about engagement generic, but it's really the engagement for what? It's the engagement to actually change, as was said here, inpatient for care, inpatient for prevention. So if you can give me the first slide or the next slide. So I will give you sort of where we are in the journey. So after 100 years of neglect, somebody would say after 100 years, we need to commemorate and celebrate the discovery of insulin. So it's a sort of double flip to this coin, right? But after 100 years, many people with type 1 diabetes do not have access to insulin. 1 in 2 of 60 million people with type 2 diabetes who need insulin do not get the insulin they need. So we can talk about innovations. That's a very popular word, but the innovation, the discovery of insulin has not yet been shared by all those who are in need. And the same goes for basic technology are not available, limited access to health professionals and primary health care, insufficient health promotion activity. So this is where we are coming from. So let's move together. Next slide, please. So our ask is a long-term engagement. It's not only these 3 days, and we have to together find out how can we be sure that lived experience and people living with diabetes actually can be part of the solution. Because the Global Compact is not meant as an advocacy sort of event. It's not the high-level summit that is happening on the 14th of April. Our aim is to have a compact for solutions. So we will launch the compact on the 14th of April together with the government and the University of Toronto. And hopefully we will be able to see things happening in a big way already when we go into the high-level meeting for NCD in 2025. And for sure, we need to show progress when we come to the 2030, where we will be asked, not we, but all the member states of the world will be asked, did you achieve the targets? Did you actually manage to get a reduction of 30% of premature mortality for those living with NCD and among them diabetes? Next slide, please. So at the moment, we have had a golden opportunity, which is actually the flip side of a horrible crisis. and crisis, and that is the COVID-19. As we have seen, it has been like an X-ray. So we have been talking about the deadly interplay between COVID-19 and NCD. And we still have a long way to go to actually make this picture really integrate into the decision makers of the world. Last time we checked the country response and preparedness plans, only 16 of them had NCD included. So we saw already in our survey in May that 50% of countries has disrupted treatment service for diabetes and diabetes-related complications. So that's the picture of COVID. Next slide, please. So if we summarize, we could say it's a deadly interplay. We know that people who has diabetes and other NCDs are dying more than other people, and they are also getting more severely ill. We know that there is a lack of diagnosis. It's untreatment. So even the supply of insulin, which was already impacted before COVID, has been even more impacted. And we also know that there is an unprotected situation with less healthy food, less physical activity, and also unfortunately push for alcohol, sugar, and tobacco during COVID. Next slide, please. So the Diabetes Compact is a compact for bundling solutions. And just here you can see a familiar situation for a patient with diabetes. And she had her leg amputated. And she's not alone. And also another thing we need to take into consideration, and the first person that told me this story was actually the president of ICRC. And he said, most people don't know that more people in refugee camps has their leg amputated because of lack of insulin, not because of landmines. So we also have emergency as a specific focus. Next slide, please. So the Diabetes Compact is also a compact for bundling solidarity. So one of the member states that really support this compact to come to fruition said, why don't we look at what we do now for access to vaccines for COVID? It should be the same for many, many other diseases. I totally agree. The act of solidarity counts also when it comes to chronic diseases. Next slide, please. So the mandates of today is manifold. So I don't go into details here, but we have had several high-level political declarations in 2019 on UHC. And of course, the way we need to go is to have diabetes treatment as part of the universal health coverage. It's in 2018 high political declaration on NCD and actually also on TB, where diabetes is a strong comorbidity, and also the political declarations before this. So we are sort of mandated as WHO to do such a thing as building a compact. Next slide, please. Yeah, so this is more of the same. So I just jump this one and move, Menno. So you might have a question, okay, what kind of sort of coalitions, compacts do we have? And if you look at this, you can see that there has been a request from member states, and we have had sort of collaborations, networks, and so on. And you see some of them. This is a partnership on maternal and child health. There are TB partnerships. There's the Gavi Alliance, the Global Fund, but also UN Road Safety. We also have a UN Interagency Task Force on NCD, which has not been funded in the similar way. And we have a lot of smaller and looser network. As part of the journey, we will have to find out how do we want to go with the compact. Next slide, please. So why a global compact on diabetes? We think it's very important to make a national case and narrative. We need to bring out of the shadows the power of the people with diabetes. We need to recover from COVID-19 and build back better. And we need to enhance the public profile of the global coalition of partners working on diabetes. And this is something we have seen through the journey so far, through our consultations and through our knowledge of data. Next slide, please. So the vision so far, I would say, and this is where we need your help. Maybe this is not the way to speak about the vision of an initiative like this, but it is to reduce the risk of diabetes and to ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality management. Of course, it has to be the vision, but do we have to speak to it like this? Will this really speak to all the stakeholders, the people living with, the healthcare workers, the policymakers? Next slide, please. The objectives of the compact is to protect, to reduce major diabetes risk factors. As my colleague Francesco Branco spoke to, we know that obesity is one of the, and would be one of the best, let's call it tracer conditions and diseases to look at when we speak about diabetes. We want to detect, we want to include diagnosis and treatment of diabetes as part of healthcare, universal UHC and primary healthcare. We want to treat and we need to scale up treatment, and we want to recover. Next slide, please. And I think somebody already mentioned what was learned from the HIV movement, nothing for us without us. And this is what we want to live today. And Guy will come back to this. And thank you very much for Svetlana's Axelrod, very important initiative to really look into a framework for engagement. I think we need that. And we will be so happy to be the first one to exercise and use this framework. So the main emergent themes is meaningful engagement that activate agents for change from talk to walk, and actions we want to see. Next slide, please. So I'm now going into a series of slides, and it's not because I'm giving you a lecture, but it's really because I want to share with you what all the different consultations has come up with so far. And again, this is because I hope it will be an inspiration, because we need to answer the question, engagement for what? So answers all partners are searching for is things like joint narrative. This has come through all the consultations. We need to be able to speak with the ministers of finance. We need to have a global price tag. What is the cost? What is the return of investment? We need to be able to show the progress for SDGs when we work on diabetes. We want to include human rights perspective, the know-how. There is a need to really describe routes to better diabetes care. There can be campaigns, roadmaps, global action hubs. It can be identification of already existing hubs. We need more guidelines. So part of what we are doing now is to map out the research gaps for diabetes. And of course, it's WHO's role to do this normative work. We for sure need innovations. And it's pretty interesting that just now, in the recent months, we have had some hopefully real innovations to address thermal instability, which has been a problem for many, many, many years. We need to get to scale. So what is the theory of change? How can we move from small, very, very specific actions, maybe in a couple of primary healthcare centers or in some small districts of a big country? How can we maximize impact? How can we build commitment, build capacity? And also the question about accountability. What needs to be done to be sure that we can hold ourselves and each other accountable for whatever we agree to do? Next slide, please. So we have had all these kind of consultations since we started to plan the compact. The first one was a workshop on access to insulin together with Rogerio's department, but also Clive Ondari's department on access to medicines and devices and on regulatory measures. We also had an expert consultation, a stakeholder consultation. We announced the Global Diabetes Compact with high-level people, also with the Lancet Commission that was mentioned by some of you. We had the hearts meeting, which is broader than diabetes, it's all the cardiovascular diseases, and it was an agreement there to also include the partners from diabetes area into this space. And also we had a very important dialogue with the pharmaceutical and medtech industry for insulin and devices. Next slide, please. So I will not go into detail. I have a summary slide in the end, but this was from the first workshop on insulin and associated devices. And as you can see, there was a commitment to action, addressing affordability, sustainability, addressing quality, availability, quality of data, also needs for still research, innovation, and development. The next we had was an expert consultation. Next slide, please. And a stakeholder consultation, and again, advocacy, meaningful engagement of people living with, as we have started today, really looking to the knowledge gaps, develop missing normative products, improve care, develop corporate, coverage targets and monitor progress, availability, quality data, innovation, mobilizing international and domestic resources. Next slide, please. And the expert consultation were, of course, much more granular. This was high-level technical experts. Some of you were also attending all of these three consultations, by the way. So here there were really population-based intervention was focused, scale up in country, primary healthcare, timely diagnosis, quality assured insulin prevention and treatment guidelines. So next slide, please. And at the announcement I already mentioned, the next slide, please. Hearts meeting already mentioned. Next slide, please. And if we consolidate, so one of the really strong recommendations was to develop global coverage targets and monitor progress. It was also to focus on availability and quality, promote innovation. And the resources needed, of course, scale up global national advocacy, close priority knowledge gaps, meaningful engagement, and improve care and increase access to essential diabetes medicines and technology. So this was really sort of the cross-cutting. And on this, I will not go into at all. But if you want to look at them, and they will be made available for you in the chat box and other places, you will see that we developed 31 asks for for the pharma and the technology industry, and we are really hoping for a consolidated change on this. And we are continuing, of course, to work on this, and we will have a new meeting with the private sector in 6 months from now. Next slide, and I'm soon to be ready. So the compact is a united action for change. So we will find different ways to call for partners like yourself, like all the people we have met, the organizations we have met. But of course, we also want to see international and national funding to be able to scale up. Next slide, and I think it's almost the last one. What do we speak about when we speak about coverage targets? And as you know very well, the most successful story on this was on HIV treatment with the 90-90-90 targets. Cervical cancer treatment has done the same, 90-70-90. We have developed also targets for childhood cancer. And we are now on the way, together with some academic partners, to look into diabetes treatment targets. We will come back to how you can be part of this process, but this is the status at the moment. Next slide, please. So if we look at the best practice, it is really what we can learn from HIV. So as you know, in the Global Fund, the people living with HIV is part of the board. They are part of the decision making. And we have tried to reach out even to them through NCD Alliance and other ways, because the reality of the fact that these people who has got an investment for HIV now are dying from diabetes as a comorbidity. So we hope that the new strategy for a Global Fund also will include NCD and diabetes and cancer. Next slide, please. So I have mentioned the products that are under development, so guidelines, research, targets, cost of action, also the narrative, which will be very much welcome today to have the and the 2 days to come to have all your inputs on. And I think I have my last slide. So if you look at WHO, after the transformation of WHO, we focus on global leadership, on the normative work called global goods, and the country support. And Bianca and Menno will later in the program tell you a little bit more on how we are working on this and how this can create opportunities for co-creation. That was my last slide. So I hope that what I managed to do, and maybe some of you are already a little bit sleepy, but still I wanted to make credit for all the people who has already contributed to this journey. So you know a little bit of their ideas. And now it's up to you to engage for what? Engage for the improved care of diabetes and prevention for diabetes. Thank you so much so far.
Thank you very much, Dr. Bente. For sure, your contribution was of high value, and I'm sure no one is sleeping. I believe that bringing the background, it's really important to understand where and why we are now. Just a provocative and genuine request that, if possible, in the next meeting with the private sector, I know that will be impossible to involve that all the civil society organizations that are attending this informal consultation, but if you could please open the room for some of them, and also for transparency reasons, I don't know if it's allowed on the WHO protocols, but if the meeting could be recorded and made available for the civil society members, that would be of great value. Now I would like to invite again Dr. Guy Fons and Mr. Joabi Walco. I already introduced Guy, and Joabi has a really interesting experience with diabetes, as he had a transplant. So please, Guy and Joabi, the floor is yours.
Thank you, Bruno. And it is now I'd like to join my colleagues, my previous colleagues and the co-chairs, because it's really a delight to welcome you to this activity. It is really a milestone activity in regard to WHO's understanding of meaningful engagement and progress in meaningful engagement of people living with diseases in general, and in particular NCDs. At the GCM, at the Global Coordination Mechanism, we have been really embracing the urgency of operationalizing meaningful engagement, not only within WHO, but also building capacity of our networks, our partners, our stakeholders in moving the agenda forward. And with Joab, and give the floor to Joab very quickly, his insights on that consultation in December will be so important. But I wanted to land on that. One of the last activities, one of the great milestones in our activities to operationalize meaningful involvement was a December consultation, an informal consultation on meaningful engagement of people living with NCDs across the NCD agenda. We really tried to dig deep into some of these questions that are already popping up. Also, what does meaningful engagement mean? What are the different layers that really drive individuals and how they can navigate health systems, not only through their specific diseases, but through those many intersecting elements that need to be considered, and then those same elements can shape policies and programs. And we have heard already, and it's been really interesting already, the presentation, we have heard the many hard facts, the passion, the reality checks, and the roadmap and the vision, which Bente has presented so well on how we move forward on this particular activity we are here today. We are here because those solutions to those many challenges, to implementing that vision, to understanding that passion, to inserting that passion into policies, interventions, those solutions will only come if they are co-created with people living with diseases, and in the particular instance, people living with diabetes. As we heard in the consultation in December, and I think this really provided a lot of impact personally. Our community was saying, when we empower communities, we empower the entire system. And this is probably one of my main points here, is that, you know, we need to understand the development of effective, equitable policies and programs, not only from a top-down sort of a policy and design implementation and design from a global perspective, but how that is then informed and cross-fertilized and responsive to the attention, to the challenges and opportunities and requests on the ground. So it really is empowering the communities to make a better system work for our those in need. I'm also very inspired by the leadership demonstrated by those lived experience, not only in the December meeting, but also in today's first hours. I'm really impressed by Bruno and Heather's insights and perspectives, and looking forward how they can further guide the discussion going forward. But the task actually for me today was to present very quickly and sort of very summarized some of the outcomes of that December meeting. So if we can prepare the first slide and we can go through that. Joab will also come into this presentation in a bit, and he'll give his broader perspective. The first slide, the next slide, please. So actually, this is a really important slide, and I think this is also the underscoring and the underpinning of our discussion today. The global health arena is beginning, and very much so progressing, in a transition away from a top-down, one-size-fits-all, and in some cases, donor-driven approaches, to really enhance bottom-up, culturally appropriate contextual models, which are being led and co-designed by national actors, local communities, grassroots advocates, and individuals with lived experience. This is what is really underpinning our activities in our scope. Leveraging, if you continue with the previous slide, please. So I just want to dig a little deeper here. Leveraging the power of local communities, individuals with lived experience, and advocates not only leads to design of contextual appropriate programs, but it will generate that buy-in we so much require and support sustainability of those health interventions we will be implementing together. We need the sustainability and the collaborative implementation of these interventions and policies. Next slide. So there is a growing acknowledgement of the importance of engaging people live with NCDs. We have heard it, and we will probably hear more examples of the successful best practices experience across other programmatic areas, and which we will hopefully learn from and leverage. But within the NCD community and the NCD agenda, it has been a delayed priority. And attention to this priority has slightly picked up, but I think there's very much to do, in particular in the NCD area across the different diseases. As Bente mentioned very well, today's exercise and activity will dig deep and sort of have a pilot experience on how we can use the lessons learned from the December meeting into very specific disease area and urgent gaps in the NCD agenda within the diabetes area. I put this slide because it's a very important slide in a sense, because it's not only because WHO likes to reference global declarations and mandates, but this is really because it sets the scene for the high-level political attention and prioritization that's been given to this stream, and also the underpinning, the health, the human rights-based approach that underpins and must continue underpinning and calling for accountability. Already in 2011, heads of state and governments committed to pursuing all necessary efforts to strengthen nationally driven, sustainable, cost-effective, and comprehensive responses in all aspects for the prevention of NCDs, with the full and active participation of people living with NCDs. This was a commitment from heads of state and government across WHO member states. It is still very relevant. I think it is still slightly underserved and underrepresented across our activities. And this is the main focus. This is the framework of where we are working under. But more important, perhaps, is the second part of that slide, which is a salient feature of the right to the highest attainable standard of health and well-being, is the right and duty to participate individually and collectively in the planning and implementation of an individual's health care. This is particularly relevant because it gives us a foundational of accountability, of commitments, of roles and responsibilities across stakeholders, but also within government and political leaders. Next slide, please. So the the benefits of engaging, of a meaningful engagement with people with NCDs have not really been fully explored, as I've been saying several times. I think we need to do much more, and we need to really fast track and explore the potential opportunities, and the existing practices, test innovative techniques, and generate new evidence to support the meaningful involvement. It has to be evidence, research-based, and we need to fill in some of those knowledge and data gaps. In this context, this is exactly the vision of the WHO informal consultation held in December. The vision obviously was to explore how WHO can employ meaningful engagement to support person-centered approaches to the co-design of NCD policies, programs, and services by putting those lived experience front and center, from the design to the implementation and evaluation of programs and services. The GCM Secretariat has been coordinating this collaborative exercise with relevant WHO departments, UN agencies, GCM participants, and beyond. And this is, as Bente also stressed for activity today, this is a medium to long-term work stream. We have triggered it very significantly in December. We are following up today and during the next 3 days. We're sort of zooming in a very particular and urgent priority, and seeing how we can learn from those December discussions and start shaping a work plan, not only for the diabetes and the Global Diabetes Compact, but for the broader meaningful engagement agenda. And very importantly, we will be defining and complementing these activities, the December and today's consultation, with additional global and regional consultations and activities that can support the Global Diabetes Compact and that can support the broader NCD agenda going forward. Next slide, please. And this is this is my last slide before I pass to Job. This is sort of the main themes. The 3-day consultation in December really was a lot of data collection, a lot of participatory processes, surveys, polling questions, and in-depth discussions. And through that, the analytics of all of that coming in, we landed on 3 main themes that were the request of the participants in the December meeting. One is to really understand that meaningful engagement activates agents of change. And that's what I was trying to say at the beginning of my slide. Meaningful engagement for what? We're going to discuss today how we can provide meaningful engagement to support the Global Diabetes Compact. But in a sense, we're also supporting that we build capacity for agents of change that can not only co-create, but then can accompany us, WHO and partners, in the implementation, the ownership, and the sustainability of these initiatives and activities. The other theme coming through was let's move from talking the talk to walking the talk. And this is exactly what we're doing today. From talking the talk at December meeting, we're now walking the talk through this very high level and impactful opportunity to impact on the Global Diabetes Compact. The last of those thematic areas is actions we want to see. This is, as Bente also very rightly said, this is about actions, solutions, solution-oriented. Again, we're moving from walking the talk from talking the talk to walking through effective solutions and activities. I may land on some of those when I come back after Joab, but really looking forward, Joab, to your comments on your insights from the December consultation. So to you.
Thank you so much, Dr. Guy Fons and the WHO team for creating such a platform for us to speak and to talk about things, our lived experience, as we spoke about earlier. I'd like to just say good morning, good afternoon, good evening to everyone from wherever you are. My name is Joab Wako, and I'm a person living with an NCD, most importantly. I've lived with chronic kidney disease for 6 years, and consequently, I got a kidney transplant 4 years ago. And that's how I started my story. When I first told my story 6 years ago, it was one of the most vulnerable things I've ever done. And I think a lot of advocates can talk about that. And so when we had the consultation in December last year, it was so nice to see that the power of storytelling, you know, when you tell your story, that vulnerability actually connects with other people. And that's where the power of our stories are. And that came out very clearly in the December consultations, where so many people have connected with my story personally and with your stories as well, I'm sure. And that's where the change is. That's where the beginning of change that we're looking for is. And then it's also led to such platforms where it's co-creation, where we can co-create. and our stories actually matter, you know, and I'm here to tell you your story matters, because when I first told my story, I didn't think it would make a difference. But here I am 6 years later, and my story is still going. I'm still an agent of change, and very happily so. The next thing that really stood out for me was we are the experts, like empowering us as people living with NCDs to become the experts. So transferring the power to people with lived experience is very key, very important, and especially for young people living with NCDs. It's so important for us to be empowered to stand up and realize that our stories and what we've gone through can create change and a difference. We need more involvement before and during, during, and after the decision-making table. So this was a really key point from a good friend, Cornelia, who spoke about we want to be involved before we're at the table. You know, like when they're cutting the vegetables, she made a comment on how when we're cutting the vegetables, like we need to be involved before the issue gets to the decision-making table. And that is a very important point from the December consultations that I would like to highlight and bring back so that we can be in the whole process from before, during, and after. And lastly, one thing I'd like to raise is capacity building people living with NCDs to effectively engage leaders and decision makers with the necessary resources to embrace and implement the concept of meaningful engagement at a country level. So when we're telling our stories, we want to move away from a tokenistic approach and be more meaningfully involved and engaged so that when our governments at my country level, I'm in Kenya, when we're doing something to do with NCDs or, for example, for kidney disease or transplantation, I'd like to be involved and give my input because I've lived through it, I've gone through it. So many of us have and know the gaps in the healthcare system. So as we navigate these healthcare systems, we need to be able to be on that decision-making table as they're changing policies and bringing these changes that we advocate and really push forward. And lastly, a human rights approach, you know, where people, all movements like the HIV movement that we've spoken about, it's powerful because of the people on the shoulders the movement rests on. You know, we are powerful agents of change and our stories make a difference. So it was really key that even in the December consultation, that it's based off people. It's a people-centered approach. We are the ones who are leading it and we're the ones who are carrying this movement. So I'd like to second and really quote Dr. Bente's presentation on We Hold the Power, and yes, we do. So we need to continue to hold hands, come together. It's not about your specific condition. We all have commonalities that we go through as we are seeking for our healthcare. And that's a really, really important thing that we spoke about in the December consultation of people living with NCD. Thank you so much, Dr. Guy Fons, and back over to you.
Thanks so much, Joab. That's, you know, your co-chairmanship in December was excellent, and your perspective and insights then were very useful discussion. But I can see them coming through now, and you are an agent of change, and I hope you can help us build capacity for more of those agents of change that are so necessary. My last slide, Jack, if you'd go back to that. This is the only slide I have left, so I'll try to go through it. But actually, this is maybe the more important of the slides. The themes I mentioned that came through that discussion were then fed back into the 3 days, especially at the final day, the third day, and we tried to land on how the community there at that consultation was sort of developed. So our next steps, what would the next steps look for that community? And I think that will also be very important to feed into the discussions later today and in the next 2 days. By the way, for your information, the report that you see the cover page there, Nothing for Us Without Us, the report of that consultation will be officially launched on the 22nd of March, and we'd be happy to share with all of you the link to that report once public. But let's look at those recommended next steps. The first one obviously is a strong call to establishing a knowledge base on what exists, what works, what lessons have been learned, and what can be adapted and scaled. This is really understanding the still growing knowledge and data gap that exists on what is the impact, what are the numbers, what is the data that can drive and also sustain meaningful engagement. And this is something we'll be working on with our community moving forward. The second recommendation is exploring alignment and integration with other lived experience communities. Now, identifying these synergies and lessons learned from other programmatic health areas are extremely important because there's been huge progress and advancement in incorporating lived experience into the governance structures, not only, but also into design implementation models and approaches, which could be so relevant for developing the Global Diabetes Compact going forward. But also because practical steps should be outlined on supporting, aligning, and where possible, integrating into these existing frameworks in other programmatic areas with the aim of building comprehensive, integrated, and resilient systems that can really guide us into the UHC agenda implemented through a very strong primary healthcare platforms. The third recommendation is to conduct an extensive stakeholder mapping, continue mapping our stakeholders involved, and in particular to identify and detail those voices at risk of being left behind and marginalized groups who have the most to offer with the least opportunities to contribute, and the most to offer because those are really the pain points in how to really design contextual policies and services. The fourth recommendation is additional focused and contextual consultations which bring together diverse voices. This is exactly what we're doing today. This particular consultation is in essence a pilot testing of this approach and the many other lessons learned from December. The fifth recommended next step, renew advocacy efforts focusing on the power of agents of change. So this is really, really need to underscore the narrative, building a concrete, progressive, innovative, and co-created narrative that can shift the focus of lived experience across the NCD agenda, but in particular today, how we're going to build that narrative, the advocacy communications efforts for that will underpin all activities in the Global Diabetes Compact. The next, and there's only two more left, the next is outline funding options and models for the inclusion of people living with NCDs. And this is really important, and this is a collaborative community effort and to explore options and models for sustaining financing of people living with, of the incorporation of and inclusion of people living in structures and frameworks with concrete funding options, not only from WHO, but also from our partners and civil society itself. And the last one is our next step to co-create an action plan with people living with NCDs to support WHO in particular as a UN agency, the lead global health UN agencies, and the respective member states in adopting meaningful engagement. That will be the long-term goal of our activities that will build on today's and the next 3 days discussions, also in December. But our end game would be to provide clear guidance and action plans on how to incorporate in WHO and across our member states. So I think it's a very hard work plan ahead of us. These 7 points, we are already working on most of these 7 points in identifying next steps, and we may hear some of that being incorporated into discussions during the next 3 days. So it's a huge progress towards meaningful engagement. I look forward to discussions during the 3 days, and we'll be very active and participating in those. Joab, I hope that you also be participating in our breakout sessions and bringing in those insights from December into the discussions.
Well,
thanks so much. So back to the co-chairs. Thanks so much.
Thank you. Thank you very much for those perspectives. It's always good to hear the stories of people, the real stories of people living with the condition. We want now to hear from 2 people living with diabetes. They are just going to give us briefly what is their story and what is their vision going forward, and what are the opportunities for engagements of people living with diabetes. We have Apurva Gomba from India. She's from Type 1 International and also Beyond Type 1 Jocelyn Diabetes Center. We also have Tara Smith from Beyond Type 1. She's from the United States. I think we'll start with Apurva. Over to you.
Thank you so much. So greetings to everyone, whichever part of the world you're logging in from. I'm feeling very honored to have this opportunity to be a voice for many people who are living with type 1 diabetes, and a room which is filled with almost 71% lived experience. And we all march towards a meaningful engagement, sharing our lived experience. Now, as just a few minutes back, we heard Dr. Guy Fons talk about that, what exactly lived experience is. And he so beautifully shared that it's not just about living with the disease, but the diverse bag of perspectives one brings as a caregiver, a supporter, a father, mother, or a provider, seeing the daily ups and downs of diabetes. I'm a firm believer in the fact that living with diabetes gives each one of us a unique perspective, a sense of resilience, and the art of insightful decision making. It makes us one in many ways an expert on what it's like to have this disease, much more than what one learns as a physician. Now, when Dr. Sir Frederick Banting awoke in the middle of night with an idea that how to treat diabetes, he had no idea and no way of knowing that he was on the brink of transforming, and in many cases, saving lives of millions of people around the world. And today, 100 years since the discovery of insulin, we are still fighting for the lives of millions affected by this disease, and many who have lost the battle to the draconian complications this disease brings along. From something to be ashamed of and needed to be concealed, it took me way too long to accept my diagnosis of living with type 1 diabetes for over 13 years. My very own daily challenges to find a balance and seeing the struggles encountered by many people living with diabetes in India, I decided to share stories and not just statistics to create a momentum around diabetes advocacy through global organization and patient-led initiatives. Now, each one of us today in this virtual room has some very heartwarming stories of diagnosis, of support, and some full of pain and grief, but some inspiring, all compelling us towards an overarching theme to live a good life with dignity and the right to health. Now, in the year of pandemic, we've all been reminding of an abiding reality that even the best laid plans changes by the vagaries of life. COVID-19 has exaggerated the existing challenges of diabetes care globally. Many affected by the disrupted NCD care services, limited access to the hospital, many rationing insulin and living, and so many of us, knowingly or unknowingly, living with isolation and anxiety. Now, there is a well-known saying, within crisis are the seeds of opportunity. Today, we need to transform how we view the road to universal healthcare and value action on NCDs, emphasizing on a bottom-up approach policy. As Bruno quoted, we are impatient and not just patient. The Global Compact of Diabetes gives all of us this important step to hope for a more inclusive care, which we've been fighting for years in the management of diabetes globally, and the urgent need for innovative solutions in the healthcare payment reform, value-based health system models. I would like to finally conclude by just laying down some opportunities for engagement with the Global Diabetes Compact. And this has to be done in priority. We all come from a diverse community, a diverse background, and we all have those skill sets. It's time we bring them all together and collaborate to step ahead through this Global Diabetes Compact. There is the importance of adding value and emphasis to lived experience is very important. Identifying people lived with diabetes as the key stakeholders, getting them on the table and being part of the decision-making process. The journey has just begun. Focusing on evidence-based research with Global Diabetes Compact and addressing the diabetes complications, developing new treatments, altering clinical care, and also efforts toward preventing type 2 diabetes. There are overcoming challenges, and we need to overcome those inequities in diabetes care globally and developing simplified, cost-effective models to improve the diabetes care delivery, especially during humanitarian crisis, as one we are going through right now. Improving affordability and access to insulin, it has been a challenge and has to be dealt now. We need to work towards innovative payment models and insurance strategies. Also, there has been discussions about regulatory system, which Dr. Guy Fons and Dr. Bente talked about. We need to create momentum momentum around not just living, but thriving with diabetes through modeling mental health support, education, combating that stigma that I have dealt with myself, and community intervention strategies. There is so much to learn from one another, so much experience we bring along, and so much skills we all coming from different communities. Let's work together, building resilient health systems. Now, one of the questions Tara pointed out in the chat box, how do we hold each other accountable? Who does what? So it is essential that we collaborate and synergize to work out those global solutions, to find out answers to our own questions. So thank you to everyone who strives for change, and to all of those who have come here, taken out such an important time out of what we've been going through, and are here to improve lives of people living with diabetes across the globe. Like Dr. Bente said, it's time to co-create with WHO and move forward by holding our efforts accountable. Thank you so much. And I'm so glad I was able to represent the voices of people living with diabetes. Thank you.
Thank you, Apoorva. What a beautiful speech. Good morning and good afternoon to everyone, depending on where you are. Thank you to the WHO for inviting me to give a keynote today on the lived experience for people with diabetes. This is going to be a highly engaging series of meetings, and it's truly an honor to be among all of you. So my name is Tiara Smith, and I've been living with diabetes since 2017. And I've been diagnosed with diabetes twice, but I'm going to touch on that a little bit later. But first, I'd like to say thank you to my amazing colleagues at Beyond Type 1, including Apoorva, as well as my close group of sister friends, one of whom is on this call today. These are friends who I've made in my short time in the diabetes community, and you are why I'm making this speech, and I'm dedicating this speech to all of you. Leading up to this meeting, I've asked myself, why am I here? I guess I should be a little bit more honest than that though, because I ask myself that question whenever I feel like I need to be reminded of my purpose, not just in this profession, but in life in general. And my answer always comes back to be of service. It's a concept that's deeply rooted in my upbringing and one that I value as a person living with diabetes, as well as a diabetes advocate. Like I mentioned earlier, I've been living with diabetes since 2017 and was diagnosed twice. First with type 2 diabetes, and later then with a lot of diabetes, nearly 2 years after my original diagnosis. My story is one of many examples of how being of service to others can change lives. However, unfortunately, my doctor who diagnosed me with type 2 diabetes was not in service to me, the patient. And I remember his words very clearly. Well, you have full-blown diabetes now, as if I'd won the lottery and tried to develop diabetes. And I can confirm I did not try to get diabetes, but I am trying to win the lottery because I think it'd be nice to have a little bit extra cash in my pocket, right? But with an A1C of nearly 16% and a blood sugar reading of 556 or nearly 31 millimoles per liter, he gave me what I call the basic three. Medication, I was on insulin and metformin, general nutrition advice, which I was studying nutrition education in graduate school at the time of my diagnosis, and a warning of the consequences of not controlling my diabetes well. And then he sent me on my way back into the world with a life-changing diagnosis with a note of, hey, I'll see you again in 3 months. Absolutely no guidance. And for nearly 2 years, I searched for a type 2 diabetes community that went beyond just recommending keto or saying that I could cure my diabetes with some herb or drink or whatever type of thing someone was selling. I wanted someone to show me what it was like to live a healthy, happy, quality life with diabetes. But at that time, I realized that I was going to have to be my own example because I couldn't find anyone else out there like me, not another 25-year-old at the time who had been living with type 2 diabetes. Also at the time, I was unaware of the different types of insulins, type 2 specific drugs, and diabetes technology that's designed to make living with diabetes easier. And I learned that these were options that were available shortly after joining the diabetes industry professionally at Beyond Type 1. And that only added to the inferiority that I felt being treated as a type 2 patient. So you can imagine how others feel who hardly have any exposure to our industry at all. At this point, I had already seen several healthcare providers, none of whom had bothered to tell me about these different options that were available to me. However, this changed after an endocrinologist I started seeing heard my story and had me tested for type 1. And then I found out that I had LADA. But little did I know that my treatment from healthcare providers would change. Suddenly, the recommendation of pumps and all this tech and mealtime insulin and learning what bolus and basal insulin means, as well as getting a CGM, were suddenly on the table. It felt like it was an overnight process, going from being treated as a type 2 and now officially being treated as a type 1 patient. Suddenly, all of these providers were of service to me, the patient. To put it lightly, my emotions range from relief to frustration. Relief for getting the right care, obviously, because a type 2 misdiagnosis can be deadly, but also frustrating knowing that I had been treated differently and knowing so many others with type 2 diabetes has similar experiences, getting the diagnosis, the pamphlets, and the note saying, "I'll see you again in 3 months." So again, why am I here? I'm here because I'm of service to a community that continues to be underserved from all walks of life, but sharing the commonality of having diabetes. I'm here because I've heard my story too many times, and the feelings of loneliness, shame, and guilt, and the feeling that you're not enough, even though you're trying your best, but your best may be only as good as the resources that are available to you. And it is quite literally my job as a senior project manager of Beyond Type 2 to provide some resources with practical tips on for people living with diabetes. But still, so many people lack the access to obtain such information, and so many others rely on patient advocates to relay such information. Also included in that feeling is that your life is over and that diabetes' ugly consequences are inevitable. However, I'm also here to help bridge the gap between the type 1 and type 2 communities and show that we share a lot of similarities. Since I've received the right diagnosis, I actually find that I still have a lot of the same worries as when I was being treated as a type 2 patient: affordability, access, and of course, complications, and probably others that I haven't mentioned yet. However, the compassion and empathy that we give to people with type 1 needs to be afforded to people with type 2. And I'm also here today with you to learn about diabetes through your eyes and through your experiences, including cultural and social norms. I'm here to learn what we have in common and where we differ. I'm here to contribute knowledge and hope it leads to actionable steps that will improve the lives of so many people around the world. I know my story is just one of many, but there are so many that need to be voiced here. I've seen the power of what the diabetes community can do. I've seen what happens when people share their stories. Our communities are stronger with each voice that comes to the table. As representatives around the world, we have the privilege to gather like this. We represent not only ourselves, but the voices of those who we've chosen to be of service. I know we only have 3 short days together this week, but if there's a takeaway from my speech today, is that being of service to people with diabetes is an attitude that should guide our discussions and how we choose to move forward. Keep that in mind as we work to improve the lives of so many around the world. I hope you take time to ask yourself today and later this week, why am I here? And to use that to be of service in the best way you know how for our community. Thank you.
It's hard to find any words after this two powerful and youth women share their thoughts, perspectives, and reflections. So thank you very much to both of you. And it's an honor and a pleasure to have our communities represented by both of you. Thanks a lot. So now I would like to move and bring a different perspective from David Chimpata, who is the Senior Advisor on Social Protection for UNAIDS. So please, David, the floor is yours.
Thank you very much. Can you hear me?
Not very well, David.
Okay. Can you hear me now? No.
It's a bit better now, yeah.
Maybe this that better?
I think it's probably okay.
Is this better?
Yeah, it's better now.
Okay, so thank you so much for this. It's really a great honor for me to speak after this excellent presentation. I work with UNAIDS across WHO, and I have been living with HIV for 30 years. And one of the key things that I always look for whenever I go to see my doctor is whether I have diabetes. And fortunately, in my last exam, my doctor says, no, I don't have. But I do have close family members, one whose leg was amputated. So this is close. This is a close topic to me. And I want to share with you from UNS, from the perspective of the AIDS movement. And if I can have the first slide. Can I have the first slide, please? Thank you very much. Most of the issues I'm talking about are what has been said by Tara and pretty much most of the speakers, and they are mainly from this document that we have produced as UNAIDS Communities Make the Difference. Next, please. So why is diabetes an important area for people living with HIV? We learned from this presentation about some of the risk factors for diabetes, and most of those risk factors, including age, family history, race, weight, smoking, drinking alcohol, inadequate diet, and exercises. We learned these are risk factors, but they are also common among those of us that are living with HIV. And at the same time, for many of us who are living with HIV, we have an additional complication because some of the medicines are associated with insulin resistance, and some of the medicines, mainly they were the old ones, but we are seeing the new ones, like tenofovir and dolutegravir. Some of them are associated with increase in weight, which again increases our risk to getting HIV. And we see in some of the high prevalence countries of Eastern, high HIV prevalence countries of Eastern and Southern Africa, that the prevalence of diabetes is between 4 to 10% among people living with HIV. In other developed countries, it is even higher, but overall, diabetes is increasing among people living with HIV, as many of us live longer lives. Next, please. And a good entry point is that many of us are living with HIV. I didn't know that I would be in my 40s. Now, this year, I'll be going to 50. Next, please. And next, the next one, please. And many of people living with HIV, like I mentioned, are living longer, but we see that by now there should be about close to 7 million people living with HIV who are 50 years older in low and middle income countries. And old age is a risk factor for diabetes. So this is a big issue for us in low and medium income countries. The projected number of people that are living with HIV who are older than 50 is going to go to below 2 million. That is in high income countries. Next, please. And what has been happening now to combine aging with HIV, some of our national AIDS program documents are including issues to do with older age, looking at the risk factors, the services, and the kind of evidence that we do need to address HIV in the context of older age and increasing risk to non-communicable diseases, including diabetes. Next, please. And this meeting is about what can we do to meaningfully engage communities that are affected by HIV. So if we have a lot to share, the battle is still not over. These are some of the things that we are still encouraging countries to do to strengthen the role of communities. They may apply to the diabetes community or not. One of them is that we have to give voice to communities. I think as it's happening here, we have to also support the engagement of communities, and we have to fund the community-led work. My experience starting, we went for months without funding, and I know that many of our diabetes colleagues, that might be the case. We have to push for policy reform. One of our colleagues spoke about the high cost of insulin. So how can we lower the price of insulin? We have to strengthen the capacity of our communities to manage their resources, to manage their affairs, but also to actively engage some of these processes. And we have to recognize the work that communities do and really give it some kind of formal space in what we do as the UN agency. And I think the other thing to WHO is that we have to employ people from our community. There are many of us who are living with HIV, working in UNAIDS in different areas, and we are able to really make sure that the policies we do as UNAIDS speak to the health needs of those of us that are living with HIV. Next, please. And at the country level, I think there are many things that countries can do. In some countries, it's very difficult for functions. So somehow the governments must invest in the communities, and we have to pay volunteers. There are a number of, we had excellent stories from colleagues here, and my sense is that most of them may be volunteers. I think we have to find ways of paying them. We have to lead by example, giving them space in our formal structure. We have to remove the bad laws that make it difficult for different groups of communities to get together. And we have to make the data to count. We have to make the data to count, because in some cases, when the policymakers see the data, it can really help us advocate more strongly. Maybe as I end with my last slide, please, I just want to offer some personal reflection. Next slide. Some personal reflection on really some of the transformative parts of the AIDS response. This may apply to the diabetes response, or they may not. But we were lucky in the AIDS movement. There was a very strong international solidarity. Our colleagues in the north who had access to HIV treatment said this was not enough, that we live and others die. So we had colleagues from the US here in Europe, Canada, really advocating that the right to access to HIV treatment belonged to everyone. We had some colleagues who were medical doctors, and some of them, for me personally, Dr. Rachel Bagley, she works with WHO here, really one of my heroes, bringing some medicine from the UK to us in Africa. Because we couldn't access them. She, they really trying to bridge that gap. So we had this international solidarity, but also working with pharmaceutical companies to reduce the cost of their medicines, to make their patents available for public use. Interestingly enough, we were very lucky to actively educate ourselves, so much that we could engage at different points of the AIDS response. And in some cases, some of the trials on new drugs, because we were on the boards that were sitting there, we were able to quicken them, because we could say that from our evidence, these drugs are making an impact. So that really helped. But I think through this push, there were other concrete life-changing parts of the response. For example, in 1983, we had what we called the Denver Principles, which transformed the response, began the transformation of the response from looking at people living with HIV not as patients, but as equal partners in the response against HIV. Through the Denver Principles, we tried to change the language that was being used. Instead of being used as victims, we were saying that talk to us as people living with HIV. Instead of firing us from our jobs, we were saying, look, as long as we are fit, you should not fire us. And also advocating for our sexual and reproductive health rights. Then the Paris Heads of States Summit in 1924, attended by 42 countries, moved even a step further to recognize that we cannot work on HIV without the meaningful engagement and leadership of people that are living with HIV. So that came, the GPA principle, the greater involvement of people living with HIV came out of that, and it became a norm that whenever we are talking about HIV, we have to have people living with HIV, not just at the table, but behind the scene planning and organizing. But I think also critically important is that many of us came out, for me, I was given 6 months that I would die. That was 1991, that I would die in 6 months. So I joined the colleagues who had shared their experiences to really advocate about this. So this really helped to give this issue a human face. So all these, in a way, did help to really push that that those of us who are living with HIV are recognized as experts and are included in our structures in UNAIDS. Not only do we work in UNAIDS directly, but our board also includes that. But of course.
Okay, thank you very much. Dr. Chipanta, I'm sorry I have to come in. We are running a bit behind time. Maybe just your last sentence to just wrap up before we welcome the next speaker.
I finished that. Thank you. Just to say that not all movements are open, but we can create the pathways to achieve what we need. Thank you.
Thank you so much for those interesting perspectives about the involvement of people with HIV and the lessons that they have for us, people living with diabetes. At this moment, I want to hand over the mic to Elizabeth Fiesta, who is the founder and executive director of Type 1 International. She's going to give us her brief presentation on best practices for community-led governance and other lived experiences. Over to you, Elizabeth.
Thank you so much. And thank you, David, and all the other speakers. It's been wonderful to be here. I think, again, yeah, one of the benefits of things being so virtual now is that so many of us can be here together for this, and we can hear as many voices as possible. So what I'm going to be sharing in the next 10 minutes is really building on some things that we just heard from David and what the themes that we've heard so far. But if you want to get the slides going, I will jump in. And yes, I've already been introduced, but I will say I've been living with type 1 diabetes since I was 4 years old. So don't really remember life without it too well. And going to be talking about community-led governance. and a little bit about what that means and hopefully how that can tie into this process here in this consultation. So very quickly about T1 International, we believe in a world where everyone with type 1 diabetes and all types of diabetes really, although we focus on type 1, we do work with and for people with other types of diabetes. And we want everyone, no matter where they live, to have everything that they need to survive and achieve their dreams. And we try to reach this vision by working directly with local communities and advocates and giving them the tools that they need to stand up for their rights so that access to insulin and diabetes supplies can become a reality for everyone. And we also have a stance that we do not accept funding from the pharmaceutical industry or any entity that would compromise our ability to independently advocate. So we really want to truly represent patients as much as possible. So to jump right in, if we can take a quick poll, if you could, I can't remember if we're doing this on the Slido. Oh, we are. Fantastic. So if you can hop back to Slido, if you're able to, if it takes you to, I did this myself at the beginning of the day. If you just go to slido.com and it asks you to put in a code, that's the code you will input. And if you could just answer how you best like to offer feedback to an organization about their work on a project or the work that they're doing in general. Do we provide options for them, or can people type in? Oh, fantastic. This is all set to go. So would you like to provide your own input through a survey? I know we did some surveys for this WHO process, or through a focus group, or through directly being in communication with the organization. I love honestly, somebody put, so I think people are entering their own answers, which is great. We've got a lot of different answers coming through. And it's great to see there's also different interpretations, understandably, of the question, but we've got focus groups, direct contact, Twitter, anonymously, understandable. You don't know what the impact of that may or may not be. Oh, this is really great to see. So I know that we have limited time, but hopefully you all can see these different answers, and this will come back and hopefully be useful for, as I said, this process, and useful for organizations in general to hear how people want to input, because it depends, and there's a lot of different ways to do that. So in interest of time, I think we'll move on to the next slide, but we'll be capturing this information, right?
Yes, all of it will be captured.
Fantastic. Great. Thank you so much to those who have answered. So what does community-led actually mean? And there's a couple definitions here that I just wanted to make sure that we're really clear on, again, especially for the breakout rooms that are to come, so that we have a clear understanding. Community-led action happens when people come together, wherever that may be, whether it's in their town or their state or their country, or like us together here from many places all over the world, and recognize that it's within our self-interest to work together to address a shared need or concern. And then community-led governance is really carried out where decision-making and leadership is by and with the community that is the most impacted. And that's what we've been talking about in different ways today. And that's what T1 International tries to do, and kind of what we were built on, is being led by the global patient community. If we can go to the next slide. So just again, making sure we're really getting that point home. It's ensuring that patient voices, or the voices of people living with diabetes, I know there's difference in terminology of what folks prefer, but people who are living with the condition are an active part of all decision making. Again, the things that I'm going to be sharing today, I'm not purporting that T1 International is doing this perfectly, but we're going through a process right now where we're looking at our values and our strategy, and we're working with a great group called the Colibri Collaborative, who are really helping us to make sure that we've woven in, which is already a part of our culture, to be led by patient voices, but to make sure that that's a real part of not only this piece of strategy work that we're doing, but how we act as an organization. So some examples of community-led approach. I just mentioned the values and strategy work that we're doing. We're creating surveys, we're having feedback sessions, we're doing focus groups, and trying to create a variety of ways, anonymous and not anonymous, for people to provide feedback and to make sure that we're hearing as many voices as we can, particularly voices that often get left out. Maybe they're from less represented groups. We're also exploring things like participatory budgeting. That's a big word, but really it's sharing the entity's budget and asking for ideas of what the money should be spent on and how it should be spent, rather than just saying, this is the budget, this is what we're spending, or we don't have any money for this. It's really trying to be an open and transparent process. And then building community input into what we call at our organization standard operating procedures. So the way that we create a new document or build a new resource internally, we have a process that makes sure that we're getting patient perspectives and patient voices rather than just building something without a lot of input. And then reinforcing all of this in the community and organizational culture through what we share out with the team and what we prioritize in our conversations. And this all takes a lot of work. I just want to be clear about that. It's, you know, we are saying here as patients, we're expecting this of the WHO consultation. We're expecting of it of a lot of the organizations that we support or work with. And it's hard. I'm just being honest, T1 International is a small organization with limited resources, but we're doing our best to be as transparent as possible so that we know that we're really being led by what is most important to the community. We can go to the next slide. I've talked about accountability and transparency. So just want to make sure I define those words. Accountability is an obligation or a willingness to accept responsibility for actions. So taking an action and then being able to say, yes, we did it for this reason, or no, we didn't do it, and these were the consequences. And that's really important for obviously every person, but also for every organization to be able to be accountable for what they did or didn't do, and to try to do better if there are ways where they can do better. And transparency means operating in a way where it's easy for people to see what's happening. So as I said with the budget, maybe you would be open about your budget or about the processes that you're carrying out, and just making information clear and easily accessible. Next. And so this is just one example of a piece that we're practicing, and I've got Calibri's logo here just to, again, acknowledge that we learned this really simple practice from them, which is we try to put out a chart after each community engagement that we undertake to say, here's what we heard and here's what we plan to do about it. So this one example here is about language, and this is something that is present in this today and in a lot of what T1 International does, which is the primary language is English. And we acknowledge that that is not accessible to everybody, especially as a global organization, and it can leave out non-native English speakers, which is not what we want to do. We do have limited resources and capacity, so we acknowledge that fully, and we try to acknowledge at the beginning of our meetings and our engagements that it is in English, but we point to where we have resources that are in other languages, and we're trying to now look at ways where we can work directly with the community to do more translations or kind of caucusing to be able to relay information back to the community. So this is just one example, but it's been a really nice tool, and I think hopefully helps make it clearer to the community what actions we're taking and why. Next slide. And then the last piece I just wanted to share with this is the spectrum of influence, which again, those words accountability and transparency come up, but it's really just a tool that kind of helps lay out where along the spectrum. So if you're thinking about a line or a horizontal graph, where along this line where you have those with the most power and influence and those with the least, where do patients or the people who are participating in a process, where do they fit? So it's really important that the WHO with us and that T1 International with our supporters is very clear about the level of influence that those who are participating have. So can we offer comments on a finalized document, or can we help create something from the ground up? So co-creation has been mentioned a lot today, and I'm really looking forward to what that's going to look like in this process. So next slide. It's quite a dense graph. Again, I think these slides will be shared, and it comes from the Movement Strategy Center. And as you can see, it's just a nice way to lay out the different stages of engagement, whether you're ignoring a group, you're informing them, you're consulting with them, you're involving them, collaborating with them, or deferring to them. And we've kind of simplified this at our organization in terms of, are we partnering? Are we informing? So we've put it into a couple of more simplified categories, but you can see here that, you know, to some of these categories are viewed as tokenism. And I know one of the other speakers mentioned that, and we do want to avoid that when at all possible, because patients and people living with the condition and people with lived experience have huge value add, and we don't want to just be sort of added on as an afterthought. And again, that's something that we really try to practice, and we don't always get it right as an organization, because the various different levels of engagement take a lot of time and they do take more resources. But I found this really helpful in the work that we do, and I hope that other organizations will too. So we will wrap it up with another quick poll. So back to Slido, if you can, if you're able to do it, or if you can't, for any reason, if you are struggling to use this tool, you can also just type it in the chat box. So what stage do you feel the WHO is at in this? Ignoring patients, informing patients, consulting patients, involving patients, collaborating with patients, or deferring to patients? I think hopefully this is, we're asking this to be able to grow in this process and to hopefully use some of those other specific ways that I asked you about at the very beginning of this presentation, of how maybe the WHO can do more to solicit further feedback and partnership with patients. So it looks like we've got, the top is involving, no consulting, we've got 54% consulting with patients. Great, so that's like the third level in the levels of engagement. So doing more than informing and ignoring, consulting with, and then we've also got some collaborating and informing. So for the most part, people don't feel like patients are being ignored, which is hugely important, since as the next slide will show, and this has been a theme, nothing about us without us. Disability rights activists, I know, and HIV activists have used this frame quite a lot. If we want to just go to the last slide. We're on the way. Oh, there's one more. There we go. On the way to truly being meaningful engaged. We would love to get to a place where we're being deferred to and fully collaborated with in these processes. And so a couple recommendations that, again, we as an organization at T1 International are working to do on the whole, but creating multiple ways for people to add input. So surveys, focus groups, community meetings, other things that people listed in that initial poll. And then working towards accessibility for everybody. So translating content into different languages, making it available with translators live, different formats. So video and picture format for those maybe who don't have the access to being able to read content as much. There are many different ways to make this information as accessible as possible. And just acknowledging that there's work to be done and being open and transparent about the work that is ahead, and that it takes time, and that knowing a plan when patients know, or people living with diabetes, or whatever the process may be, when there's a plan of this is when we aim to have these processes built out, can also be really, really helpful. And again, treat us like the experts that we are in all of this. And if you don't know, just ask us. And I think we'll have a lot of opinions to share. So again, thank you for your time and for giving us all the chance to share our thoughts and opinions in this process.
Thank you very much, Liz. Now I'd like to further ado invite Bianca Hamilton, who is the medical officer for the NCD-WHO, and also Manu van Hilton, who is the senior cross-cutting leader strategy for the NCD department. Please, Bianca, Manu, over to you.
Yeah, thanks a lot. Yes, my name is Bianca Hemmings, now I'm a medical officer in the World Health Organization, and I will go through the pillars of engagement in the Global Diabetes Compact together with my colleague, Manu. So yeah, and you can go to the next slide, please. Yeah, this slide was also shown by Bente, and careful of time, I think we go to the next slide. Yeah, this slide shows how the World Health Organization engaged with we of course engage with several non-state actors and have developed a FENSA framework of how such engagement should be. But you can go to the next slide, because I would like to focus on the most important thing in this presentation, namely the pillars of engagement. As mentioned by Bente, the meaningful engagement of people with diabetes was one of the main conclusions of the stakeholder and expert consultation held back in October 2020. But having meaningful engagement as one main conclusion does not mean that you're not important for all the main conclusions and asks. The importance of your engagement is important within all aspects of the compact. And it goes from all the way from the design to the implementation and evaluation of the compact. This slide shows the pillars of engagement, and it entails advocacy, partnership, implementation, and governance. And we would very much like to have you a part of the Global Diabetes Compact through all 4 pillars. The next slides will give some examples of how the ask from the Global Diabetes Compact could go through these pillars. And this will just be suggestions, because we look very much forward to get your input in the breakout session. Yes, you already have go to the slide with advocacy. The advocacy for priorities provided by you and a shared narrative will be very central for the Global Diabetes Compact. We want the priorities from you to be reflected in the Global Diabetes Compact through a shared narrative, and we need both to have the perspectives of type 1 and type 2 diabetes integrated. You can go to the next slide, please. We hope that the partnership will be a collaboration where you will be involved in all parts of the Global Diabetes Compact, again, from the creation of the compact to the implementation. And at the decision-making table, we would like to have you included to ensure that the decision and priorities all will be of relevance for you. And please go to the next slide. During the compact, there will be several opportunities to engage in implementation of the Global Diabetes Compact. There will be different programs, guidelines, and advocacy campaigns. Implementation is also of relevance when it comes to different levels, not only if it's a program or a guideline, but it could also be at local, national, regional, or global levels of engagement. And of course, it also comes, yeah, it's okay. We'll just go to the next slides. It's okay, we're careful of time. Yeah, this is just an example of a country support. Like I mentioned, there will be different kinds of implementation, and this could be an example of a country support. Like there is the evidence generation and prioritization, where you are so central, like you are in all parts, and the decision on delivery models and community engagement and input for scaling up. Yeah. And that's actually, I think I will do it short and then give the word to Menno, who can take over. And again, I look very much forward to receive your input in the breakout session.
Thank you very much. My name is Menno van Hilten. I've been 15 years at WHO, and it's fantastic to be here. I just have one feeling, and that is it's 10 years ago that we had the first high-level meeting on NCDs. I wish we had these discussions 10 years ago, but it's not too late, of course. It's a fantastic opportunity to do it now. So if we go to the next slide.
Menno, I'm very sorry, but your audio is cutting in and out.
My audio is cutting in and out. Is it better now?
Yeah, it seems to be better now.
Okay, maybe go to the next slide. Yes. So there are 2 governance gaps we would like to highlight, and that in addition to all the governance gaps that you've already highlighted. But one is something that you see here on the screen. It's called Power to the People. So this is a report that was launched by UNAIDS 2 years ago. And it showed that if people living with HIV/AIDS are engaged in decision-making and HIV service delivery, the health outcomes are much better. So it would be fantastic if under the Global Compact we could organize maybe a similar initiative to this one. And it's all about the power to choose, the power to know, the power to thrive, and the power to demand. And if we go to the next slide. Jack? Yeah, thanks. Another governance gap is about a seat at the decision-making tables. And this is all about getting access to financing. If you look, for instance, at the Global Fund or at Unit 8 or at the Stop TB Partnership, diabetes is relevant for all of these financing mechanisms. And it would be important to have a seat at the decision-making tables. The same is true for global agendas. If you talk about global political leadership and raising the priority giving to diabetes on global agendas, then one important forum is the ECOSOC High-Level Political Forum on the SDGs. That's a place where once a year the world leaders come together in New York and they talk about their national problems and their national priorities. And if you look in terms of NCDs or diabetes, this is hardly mentioned. And this, if you look at HIV, it is mentioned by every other speaker. So this is an example of where to influence governance. If you look at regional agendas, everything from the Arab League to NEPAD to the Pacific Islands Forum, diabetes is sometimes mentioned, but not often enough. The same is true for G7, G20, the small island developing countries. So we have managed to get issues like tobacco use in agendas or outcome documents that are adopted there, but never diabetes. So that's a huge gap. And then when it comes to domestic agendas, one thing is that if you look at the national SDG responses that are being formulated, or you look at the country coordination mechanisms for the Global Fund, there's a lot of opportunities to include diabetes and to discuss diabetes, but that opportunity is often missed. So these are two governance gaps that we would like to hear from you if you see any benefit in working on these under the Global Diabetes Compact. If we go to the next one, Jack. Then the launch itself, and we're going to discuss this on the tomorrow or the day after tomorrow, just to let you know that it will take place on the 14th of April. And if we go to the next one, Jack. Jack, if you go to the next slide. Yes, there are 3 level segments. So one is a global segment that is high level, including people living with diabetes, of course, and this is where we will launch the Global Diabetes Compact. We also hope to have some heads of state and government there, private sector, civil society, and maybe some UN agencies. Then there will be a global segment for people living with diabetes, followed by a Canadian segment for people living with diabetes, and we can discuss a little bit further tomorrow or the day after tomorrow. And then the next slide. When it comes to the functions of the Global Compact, these are 6 functions on the screen which is very much initial thinking, but it would be interesting to hear if views and to see if you can help us shape these functions further. So one is about building momentum around the shared agenda of bringing diabetes care to all. The other one, second from the bottom, is about the co-creation of implementable solutions. The third one from the bottom is about coordination of efforts and linking it to technical networks, for instance, that we're establishing at WHO. Then the three in the white area are about learning, information exchange, resources, and creating buy-in. So this is something that maybe in the work in the breakout rooms you could further reflect upon. And the next slide, I think that's it, Jack. Yes, thank you very much. Back to Jack and Elena.
Heather and Bruno, are you taking over?
Yes, we are. Thank you very much, Bianca and Menno, and we are excited to see all these engagement opportunities for the compact launch. Now I have the really challenge mission to limit the amount of speakers, unfortunately or fortunately, which is a signal that our discussion have been really productive. We are already 30 minutes behind the schedule. So now we'll give the opportunity to 5 speakers. So whoever raise their hand first, and I will ask Alina and Jack to help me on that. We please kindly ask you to keep on 2 minutes for each of you, so we'll have time to hear as much as contribution as possible. As I said, we are already 30 minutes behind schedule. So Alina and Jack will be calling names as I cannot see the hands raising.
So just to add, here we're really interested in hearing questions for Bente, Bianca, and Menno before we go into the breakout sessions. So anything where you feel like you need more clarification, any more detail, please let us know. I see Allison has her hand raised.
Hello, everyone. Good morning. I'll make it brief because I know we need to move on. I just wanted to share the fact that not only am I a person living with diabetes, living with obesity, but I just had the recent circumstance that was totally different, and I didn't think it would be. My 95-year-old father just passed 2 weeks ago. Last time I was on with you in December, my sister had passed of cancer. The point is that my father at 95 had diabetes for 40 years, and he was insulin dependent. At the point that I took over caregiving for him, even though I am a type 2 diabetic, I am not on insulin, I had absolutely zero experience or understanding about what that care meant. I learned fast. He was very cognizant and lucid, but still at 95, he needed support. He was on 2 different kinds of insulin. Subsequently, I have a refrigerator full of insulin that we can no longer use. I just wanted to share with you that there's many aspects of managing, maintaining, and looking after ourselves and others. And that I think the more information, the more training, and the more education that we have as people living with diabetes, living with diseases, NCDs, the better we are. Everybody's story is different and everybody's needs are different, but we need education. And I think that the more education that we have, as I found for my own care, was that it offered me opportunity to be a direct participant in my caregiving and thus help myself with some of the things that we talked about, which was treatment, prevention, and hopefully you move towards being better, building back better. So I just wanted to say it's not only within the medical community's responsibility to look after yourself, but I think that empowering us to take care of ourselves and others is a gift. So thank you, and thank you for everybody here today. I really appreciate it.
Thank you, Alison. I see Osarenko. You have your hand up.
Yeah, I just want to thank everyone that has presented. I'm a person living with type 2 diabetes from Nigeria. I just wanted to bring to the attention of the presenters that I don't feel comfortable they calling us patients. For everyone that mentions it here, it makes me uncomfortable. I think I was expecting that a lot of the presenters here would have been briefed that the language has changed. You don't refer to us as patient in any capacity, whether you're talking about patient in the hospital or you're talking about somebody who's living with it like I am. I'm not a patient. Even somebody in a hospital bed is not a patient, except he has complication. So please, I would appreciate, I would beg if every presenter try to work on their paper, whatever they're doing here, not to refer to us as patient, please. Thank you.
Thank you, Osarenko. Point well taken. I'm not seeing any. Oh yeah, there I see Lydia. I'll give you the floor.
Hi, everybody. My name is Lydia. I'm originally from Ghana, and I'm a nurse, and I live in Worcester, Massachusetts, and I'm type 1 diabetic. So it's my teenage son and my mother who is in Ghana. And I'm the founder and CEO of Frankel Foundation for Diabetics. I have a question because with my organization, I go to Ghana twice a year to organize health programs and in so many regions. And one of the problems that I noticed was like they lack education. And my question is, how is the World Health Organization informal consultation on people living with diabetes? Or how is the World Health Organization going to help those people living in Africa who are poor, who don't have access to clinics, who don't have access to medication, treatments, and all that? And if you go, one of the regions that I went to, we did a very big program and we had about 1,000 people. And trust me, the language thing that most of the speakers said about the difference between diabetes as an English word and diabetes in the language, they think they are two different things. And most of the patients, they go to the hospital, they get diagnosed, and that's it. No education, they don't even have the resources to follow up, and most of them end up having their legs amputated. And I saw a lot of people with amputations and all that. If you ask them why, what happened, then they will tell you, oh, they diagnosed me with diabetes and I didn't know what to do. And I had this scratch and it wouldn't heal. And eventually it got infected and they cut off my leg. So how is World Health Organization going to help countries like Ghana with people living with diabetes, not having the resources, the education and other stuff? Thank you.
Thank you very much for all the contributions. Unfortunately, as we don't have much time, I'd like to pass the microphone to Dr. Banti so she has the chance to answer all these really valuable insights.
So, I have to hold myself back because after today with all the sharing of different aspects, I mean, it's totally amazing. So, but I will focus because we have a strict chair, right? So first of all, thank you for raising, I would say, health literacy and education. It's a little bit both because it's both about healthcare workers, and education of them, and that is part of the health system strengthening. So when we talk about health system strengthening and universal health coverage, actually we cannot ignore the health workforce and the education of the health workforce. So that's sort of within the system or within the concept. I'm not saying that it's easy. We all know that very big parts of the world doesn't really have trained healthcare workers at all. Then the other thing is the health literacy. And I think we need to look into new ways. First of all, we need to partner with people like yourself that has a lot of experience in, I would say, mass education of people living with. But I also think we should look into things that has happened now during COVID, where we have seen that using digital health, using self-health in a much bigger way has come true. So I'm also very proud to have people online that is working in our health program. And we have developed like diabetes that is so far very, very efficient in getting messages out. So I think we definitely will take this into account, and we need more ideas on this one. Then I think the other comment was one on it was one on in the chat about the compact. If we are in Toronto, can we join the meeting? So when we say things are here and there, today we are in Geneva, by the way, it's virtual events, and we will discuss that on the third day, how you can both influence but also be part of that. So I think that was maybe the main thing. Maybe I would like to mention that, you know, already now we have some governments that want to fund activity at the country level. So the biggest funding so far is from the European Commission, who seed fund in 110 countries. And now also the government of Norway, which includes the country of Ghana. So we think that Ghana and the 3 other countries that are funded by Norway can be demonstration countries in this sense. So we can come back to that later on.
Yeah.
So, but this is also part of what we need your help for, because we need, you know, to raise the voices, raise the sort of the, how to say, the case for, of course, we want to support every country, but we also need to do this a little bit smart. So where we have some starting points, we definitely need to model and show what can be done to inspire other donors, other countries to do the same thing. So I think that is about what I can do at the moment. Bruno, back to you, and Heather.
Thank you very much, Dr. Bente. Now, I would like to call for a 5-minute break. Please be strict to time, so we don't wanna miss any part of this really important experience that we are all living. Just to keep in mind that everyone is invited to share their questions on the chat, and WHO will make sure to circulate them later. So now, according to my watch, is 33 past. So so 11. So we'll be back at 11:40 and 2:40 on Geneva time.
Right. I hope that everyone had an admittedly very short but good break. We're now ready to move into the breakout session. We'll do this every day. We'll do it twice on the third day even, to give everyone a chance to exchange on the pillars of engagement under the Global Diabetes Compact. Jack, do you want to briefly explain how this is going to work?
Yes, thank you, Elena. And moving to the next slide. So our overall objective of the breakout session is to explore how can Diabetes Compact ensure meaningful and diverse involvement of people living with diabetes across governance, advocacy, implementation, and partnerships. And how can people living with diabetes contribute to the compact overall? So we are going to use the next 45 minutes to break out into different breakout rooms. There will be, each breakout room will be focusing on one of those 4 pillars. So again, that is governance, advocacy, partnerships, and implementation. In each room, you will find a lived experience facilitator. Their role is to guide the conversation, to ensure the lived experience is central to that conversation and that discussion. And there will also be a WHO rapporteur there, a note taker, if you like, who will be helping the facilitator and the group come to consensus, if you like, with the discussions. And then we're going to feed back after the 45 minutes. Actually, after 45 minutes, we're going to have another short break, I hope. And then we're going to feed back to plenary. And what's really important about the feedback to plenary, now it is going to be a short feedback. I think off the top of my head, it might be a 90 seconds feedback. And of course, we're not going to be able to fully capture all the rich discussions in those 90 seconds, but please be reassured that we will definitely demonstrate the value of those conversations in full detail in the post-consultation outputs, including the report. But when we're feeding back in those 90 seconds, it's really, really important, not only to ensure the rest of the room is aware of the relevant discussions across all the breakout rooms, all 10 breakout rooms, but also we'll have the opportunity to hear the immediate response from Bente, which I think will be very interactive and very interesting and very participatory, we hope. So we'll now break out into the breakout rooms. Please note that you have the opportunity to select which of the pillars and which of the rooms you wish to attend. We are expecting that there'll be about 10 to 11 individuals per room. So please be mindful of that. If you see a room which is rapidly filling up in the first couple of seconds, feel free to take a breather and see how you can best fill the other rooms. If there are rooms which are over capacity, then we will have to move and rejig everyone around. But hopefully that isn't the case. So feel free to see how the first initial movements of individuals in terms of those breakout rooms. So I hope that's clear. Please note, if you do have any questions, and I will pass to Elena before we open up the breakout rooms, but you also can ask the rapporteur, the note taker as well, if you have any questions about the overall breakout session. Elena?
Great. Perhaps just to clarify, we're over time. This next session is meant to be 45 minutes, so the times that you just saw before won't work out, and it might not be that useful anyways, depending on where you are in the world. So just note that we're dealing with about 40 to 45 minutes of discussions now before we then head back into the plenary for a report back, kind of a rapid fire report back.
Super. Thank you very much, and enjoy your first breakout session. Hello everyone, welcome back. We're just going to wait a couple of seconds until everyone returns from the breakout rooms, and then we should jump straight into the plenary feedback. So hopefully that is exciting. I hope you had a great discussion, and look forward to speaking more soon. Super, great. I think we're getting close to 90, like 75% of our meeting today. So a lot of happy faces, which is good. Hopefully it means there's a productive and positive discussion. And thank you all for your patience with the breakout session assignment. It was much appreciated. I think we got there in the end, a little bit later, but I hope that didn't impact your discussions too much. Hopefully our co-chairs should also be in the room. Bruno, Heather, are you with us? Actually, I see two Brunos.
Yes, I am, Jack.
You've duplicated, I see.
Yes, I'm using my phone micro.
Okay, great. And Heather is also here?
Heva, can you hear us?
Okay, I think Heather is facing some connective issues. So we start calling the rapporteurs, and we kindly ask you to stick with 90 seconds each. And I'm sorry, but I'll be forced to cut you guys in case you go over this time. So the first group is governance, and I would like to call Sana Ajmal from Pakistan. So Sana, if you could please share your feedback.
Yeah, so Elena, can you please share the slide, or should I do it?
1 second.
I'm sorry, Elena, I was having some technical issue with the slide. Okay, hello everyone. I'm Sana Ajmal. I'm representing Michi Zindagi from Pakistan. I'm a person living with type 1 diabetes. So we had some very good discussion and the group was very small. So we had a lot of input from all those few members that were involved about how can people living with diabetes be included in the governance of the Global Diabetes Compact. And we started off with the suggestion to define governance, and we brainstormed this, and the suggestions we came up with was the inclusion of people living with diabetes in decision-making, budgeting, and accountability, as well as oversight. So accountability came up as a very important component. How do we create accountability between and amongst the various groups and their tasks or various parts of the projects? So tools need to be developed for that. This is what came up as a suggestion. One very strong feeling amongst the group was that people living with diabetes need to be moved beyond storytelling. Yes, we agree that we have expertise to share. We have a lot of lived experience, but we need to move beyond. We need to be moved beyond storytelling, and recognized as experts in our own right, for which WHO might need to do some capacity building for people living with diabetes on training them how decision making happens. How do we, for example, speak to each other and allow people to be comfortable in this space? Then we discussed what can be the kind of structures where people living with diabetes can be involved, and suggestions came up as the board and executive committees should have people living with diabetes having voting capacity in decision-making structures within the Global Diabetes Compact. Then Riva came up with a very important point that once WHO makes it implicit that it is consulting people living with diabetes and involving them into the governance, and this should be made out as an implicit message to the public, so that all the organizations around the world start taking this lead and start involving people living with diabetes or patient associations in that in the governance process. Can we have the next slide, Elena? All partners of the GDC should embrace the voices of people living with diabetes. So WHO and all of the partners, which may be the governments or the industry who are going to be part of this compact, should embrace the voices of people living with diabetes. We also discussed that there is a lot of tokenism.
Sana, I'm really sorry, if you could please wrap up.
Yeah, sure. Okay, so the crux of this whole is that we need to develop SOPs on how to engage people living with diabetes in the governance, and the application procedure should be open, and WHO should be able to pick and select who sits on the governance committee instead of nominations coming in from governments or from other organizations inside the countries.
Thank you very much. Now I would like to invite Crystal Boyer to report on her group that was on advocacy. Crystal, over to you, please.
Hello. I'll just wait for the slide to come up. Okay, so we had a really great discussion as well. And our question was, how can we advocate for the Global Diabetes Compact at the global, national, and community levels? And one main point that was spoken about was training. You know, within a lot of our countries, some people don't even know what the difference between type 1 and type 2 diabetes is. A lot of healthcare workers are not, you know, there's no training for them as well. And we really think before you can actually advocate for the Global Diabetes Compact, you may need to have a first step in terms of some basic training. Training is imperative for the success of any person living with diabetes, their family, the community, and the healthcare environment on a whole. That's the first point as well. Proper education. It also needs to be inclusive, and broader language should be implemented. Too many times we actually see that the separation comes from top down and not bottom up. So the difference between type 1 and type 2 being pulled apart is normally a top down thing. And that's where people like the World Health Organization should guide smaller communities who may not know how to bring them together and just show that they are inclusive, have broader language as well, available in all languages, and make it vision and hearing impaired. We noticed that was put in the chat, which is a great suggestion. And include people living with diabetes in all aspects of the decision making, and not just there, as Sana was saying, in terms of just storytelling. They need to be involved from the bottom up. What else? Right, that tokenism is really not an option. And I think that this was discussed quite a bit. And we had a clinician, actually a couple within our discussion, and you know, clinicians are not experts. They really need to learn from people living with diabetes as well. And for the WHO, as people living with diabetes within our communities, sometimes we may find it difficult to reach up and reach out to our policymakers and the bigger organizations to fight to have a voice. And it would be great for organizations such as the WHO, who have a lot of influence around the world, to reach into our local communities and suggest that they include people living with diabetes in all aspects. Because we operating as silos, trying to share our voice, it's sometimes not appreciated. And we know that you guys have a lot of respect as well. So using your voice to encourage our communities to use us to advocate. I don't know if I'm at 90 seconds.
Yes, thank you. Thank you very much. So now I would like to call Sirine Farhat to share with us her insights from partnerships.
Okay, so hi. I have to admit that it was a very fruitful conversation. The thing is, panelists, the people who were contributing to the discussion talked a lot about the importance of having like partnerships from other NGOs or initiatives that maybe are affected by diabetes, like, for example, working with initiatives that do work with kidney disease or things that are a result from poor diabetes management. We also talked about the importance of magnifying efforts of type 1 and type 2 diabetes coming together. And that way we would have a larger voice. When asked who should we be addressing or raising up our voices to, the answer was everyone, because everyone has to be involved in the process of identifying and helping others see what people with diabetes need and require to have the right education, access to information and resources. As for the part where we discussed who might be the people or people who can come and showcase our advocacy. Here we have to kind of highlight people in every country that are of high influence and that can speak up for the rights of people with diabetes and show that they have needs and that they need to have access to certain things, whether it's at the workplace or whether it's access to mental health resources, or it's not just access to medication and like glucometers. There are also other aspects that need to be kind of raised up. So these partnerships should be diverse and magnify the voices of people living with diabetes. I don't know if I have something.
Yes, Irene, I'm sorry for cutting you off, but you already reached your 90 seconds. So now I would like to invite our next rapporteur, Ethel Shima, who will be talking about implementation.
Hello, everyone. Jennifer, please, can you please put up the slides? Thank you. Just share your screen with me, please. Thank you.
Can somebody enable my screen share, please?
Should be enabled, Jenny.
Unfortunately, it's not right now, Jack. Can you give it another?
Yeah.
Thank you.
Should be now.
Okay. Okay.
Thank you.
Thank you. It was a very a large house, and we had a very beautiful conversation. Our topic was how can we support the effective implementation of the Global Diabetes Compact. We first of all had to define the Global Diabetes Compact to understand that we all understood what it meant and what their goal was. So we all agreed, we understood what their goal was, and then we now gradually atomize what we all think from a different perspective from different parts of the world. It was a large house. So the first thing we addressed was persons living with diabetes had to be part of the implementation. So you have to ensure that the universal health care is is available to everyone, and diabetes care prevention and treatment is key in universal health care, not like as it is now in the present world. And then a proper diagnosis. It was discovered that most parts of the world, type 1 and type 2 were not well defined. Some countries just classed everyone into person living with diabetes, did not separate it. So we suggested, and we came to an agreement that has to be captured from the onset, proper diagnosis, type 1 and type 2, and gestational, which is very important, which has not been getting so much attention. It should be part of the implementation that gestational diabetes is captured and brought to the know of everyone that gestational diabetes can reduce more of the problem of type 2 if properly diagnosed and managed from that onset. And then we also address that education in all this, if the society is not aware, implementation will not work. So the society, the government, the person living with diabetes need to be educated, the healthcare provider need to be educated, the carer need to be educated. So education from the primary level of a young school age.
Sorry, Ethel, sorry to interrupt you. Can you just wrap up now because of our time constraints? Thank you.
I didn't even get up to 90 minutes like others, but it's okay. Okay, well, I guess we had a very beautiful discussion. It's so much, you can see it. I cannot summarize it all in just a few seconds, like you just said, but the main thing is that we capture that we have to partner with the government needs to be carried along. The media has to be involved. Everyone in the society needs to be involved in the implementation of it. And the person living with diabetes, the carers. I just can't summarize it, so it's huge. We can see that we had so much discussion. And then proper diagnosis needs to be captured from the onset. And then the key thing we also talked about was let the cost of managing diabetes has to be made affordable, has to be reduced to everybody across the board. A global approach of the care of diabetes has to be addressed.
Okay. Thank you so much for that. Thank you. We can now have Elizabeth. She's going to give us feedback on governance. Thank you.
Thanks. Not too much to add to what others have said. So just briefly, I will share. We had a great discussion in our group, and a couple of the key themes to pull out was importantly, it's in addition to language accessibility, just to understand what is meant by governance and in what specific aspects should patients be involved, and making sure that they understand and that the WHO in this case understands what it's asking of communities. And then accessibility was a huge thing. So there was a strong opinion that patients and people living with diabetes should be definitely a huge part of governance and a part of the whole process, but reaching out to rural communities and having partnerships and systems where input and insight can be gained from those who are most impacted, but often left out of the conversations. So there's a lot more, and you can see that on the slides, but I'm aware of time, and folks have already touched on some of the other things that we discussed. Thanks.
Thank you so much. If you're done, let's have Chimezi reporting on partnership. Sorry, that should be advocacy, Chimezi. Thank you.
So much. Can you hear me, please?
Yes.
Okay. Okay, we had a very good chat on our own group, and we discussed so many things, but the key points we had there on diabetes advocacy and how we can actually advocate for this global diabetes compact. We said that there is need for we to have a very good communication. There are so many ways we can advocate, and we talked about using peer-to-peer support is also a way to advocate for people living with diabetes and support the global diabetes impact. We talked about using the right language. For instance, in any community, the language of the people should be used to communicate what diabetes is all about, and that will make them to really get what we are talking about. We also talked about using some notable individuals like the celebrities to do the advocacy, because now we are in the era of social media and we have some of these celebrities doing one thing or the other. If their attention could be drawn to diabetes advocacy, they can use their social media to advocate for people living with diabetes. And we talked about engaging with policymakers to implement the positive change we are all crying for in diabetes. And we also talked about empowering people living with diabetes so that they can have the right tools, the right information, and also have access to their diabetes supplies. We also talked about the need for people to tell their stories and use their stories to communicate what diabetes is all about. We also talked about training healthcare professionals, especially at the level of our communities, because for instance, here in Nigeria, so many people working at where we call health centers, most of them don't really know what diabetes is all about. But if they could be trained, you know, they will help, because those people working in those health care centers, they are closer to the people in the communities. They can as well help in advocating for diabetes and help in educating people what diabetes is all about. We also talked about—
Sorry, Chimezi, I have to cut you short. Unfortunately, time is not on our side. May I call Daniela Rogers to speak to us about
Thank you. Well, we also had a wonderful discussion.
90 seconds is not enough.
There is not much to, well, it's a lot to add, but we do not have the time. But one of the biggest things in regards to partnerships that was said is the importance to support the type 2 community to come forward as advocates. It was talked about the big stigma around type 2 and how much there's also discrimination and they do not always have the chance to, as type 1 diabetes, people living with type 1 diabetes, to be involved in policy making. So it was very important for us to acknowledge the need for this to change around the stigma regarding type 2 diabetes. Make sure also to meet specific targets in order to understand the needs of each community. One of the biggest things that was shown was the contrast between each country and within communities within each country. So it was important for us to understand that when it comes to partnership, every single community needs to be acknowledged and understood. For example, work in partnerships with involving people living with diabetes and the word in partnerships with them. How to engage with people also, again, at grassroots levels, including digitally, and work from bottom to up to policymakers. This was very important. It is important for us to recognize that our grassroots can eventually become policymakers and can impact not only nationally, but globally. So we need to make sure every community has the right tools to advocate, every right tool to actually work with in order to make a change within their own community, within the global diabetes compact as well. One of the biggest things for me and listening in our group was accountability. Accountability is not often taken when we work with people living with diabetes. And someone in our group actually said, who do we hold accountable? How are we actually going to know who's going to be accountable for everything that's going to be done and implemented in each country within this initiative? How do we know who to ask, and how do we make sure that in our community this gets done? Hence, that was a very important part of the conversation. We were running out of time by there, but yes, how do we know that everyone that's being a part is actually making sure this happens in the right way, and making sure they understand the specific requirements and vulnerabilities for type 1 and type 2 in order to be able to develop tools and policies addressing this particular topics. Because one of the biggest things that was shown was that yes, in some countries, type 2 diabetes has a big stigma and is very hard, as I mentioned before. But one person in our group was actually saying that in her country, for instance, it was absolutely the contrary, that most support was going to the type 2 community, and that a lot of people with type 1 were not heard, that they were not even allowed to be part of their associations. Hence, that this needs to change.
Thank you, Daniela. Thank you so much for that. Unfortunately, we just have to cut you because of the time, but we hope we'll have time to look at all those presentations and see what you had for us. May I now call upon Michael Donoghue? He's going to give us his feedback the group's feedback on implementation.
Thank you very much. Sorry, I could not find my unmute button and I was about to start speaking in that way. Now, we actually have a lot of information, but our team, knowing that we were going to be so late, we boiled it down to 3 key points. Our question was, how can we support effective implementation of the Global Diabetes Compact? 3 key things. Create a global toolkit to easily be understood for PLWD and the healthcare worker. Also, the toolkit be available in multiple languages, more regionalized, as they would say. We did realize within this point as well, and this is a sub point, is that within providing for healthcare worker is also for any information within a toolkit is also make it literate for who the audience is. So if it is a healthcare worker, or if it's a person living with diabetes, or if it's a government official, that information should be available clearly. And then the last one was immediate feedback loop, including people living with diabetes when implementing. One of the biggest concerns is when working on these types of projects is the information is pushed out one way, but it does not come back. And there's no way to, unless we have that information coming back, there is not a way in order to create additional change moving forward. So I know Bianca has more notes, but these are the key 3 points to take away. Thank you.
Thank you so much for that brief presentation. May I call upon Molly? She has the feedback on governance.
Sure. I'm just going to quickly share my screen. Hopefully you can see that. So I'll be very brief because obviously I know we're running out of time, and I mean, I think what other people talked about in the governance, I think we reflected that conversation as well. We had a really interesting conversation, you know, one of the things that I think stood out was, I mean, of course, we believe that in terms of governance, people living with diabetes should really be involved in all aspects of this. For me, one of the things I think was really important is that it needs to be structured and it needs to be well defined. I mean, we see our experience as a contracted value. So it should be something that's looked at not as sort of, it is a job as well. So for people, especially who might not, you know, take part in these things or taking part of them outside of their professions, they should also be contracted and compensated for what they're doing. Yeah, and I think also the role that it needs to be very diverse. So we need to make sure that the localized insights are also in priority, not just the global insights. We did identify some challenges, you know, if you're talking about governance, it's really thinking about who's best equipped to really speak to the lived experience. As we know from this group, it's a very diverse group. So how do we determine who are these representatives in governance of the Diabetes Compact? And also how might their biases underpin the engagement? So really being sure that we have demographic diversity, social diversity, type 1, type 2, all the other different groups to be part of this group. And then the other thing is oftentimes when we're talking about including people, we're typically saying, well, you know, people need to sort of be able to learn how to speak at the policy level and understand sort of the language that's there. But in some ways, we also need to think about better ways that we can talk to people in the way that they prefer to speak. So maybe thinking about new ways of reaching people, looking at multimedia, looking at sort of the new world and how we might be able to reach people differently than just in sort of the static ways that we've done in the past.
Thanks, Molly, for that. Unfortunately, I have to catch you again. We now hear from the last group. We have Mark Barron to give us some feedback on implementation. Sorry, partnership. Thank you, Mark.
You cannot hear me, now you can. Excellent. So I'm gonna share my 2 slides here quickly. So the idea discussing partnerships, so the role of partnerships for the implementation of Global Diabetes Compact, besides obviously the increasing its potential for dissemination and also adoption of the Global Diabetes Compact, would be also to bring the partnerships between healthcare professionals and people living with diabetes, governments to facilitate this partnership of people living with diabetes with government. So to create this channel, we believe that WHO has an important role on this, on facilitating this connection in between governments and people living with diabetes, to bring their perspective and also obviously participating in co-designing and all the decision opportunities, reach more people with NGOs, through NGOs and private sector through partnerships. So this was a reflection that obviously government should be engaged all the time, but also we should develop partnership strategies with NGOs and partners and private sector to reach more people. Also, the importance of partnership with industry to have, the products that people with diabetes would need, and also obviously all the medicines and etc. available and accessible, affordable to people with diabetes. So for this, it is important that we develop partnerships and also with community health workers, since they are the ones who will be close to the families, close to people with diabetes. Build alliances outside the diabetes space, so breaking the silos in order to be able to address issues that are even bigger than diabetes, but that would lead to diabetes. This would be an effort even to prevent diabetes. And also, we don't want to forget the importance of partnerships with funders, with donors, with the academia, since obviously to implement, we need fund and we need evidence to be able to implement evidence-based approach and policies and programs. So I think that's...
Thank you so much.
Thank you.
Thank you so much. We now call upon Dr. Bente just to respond a few comments from the feedback that we got from the groups.
I love these fantastic challenges. Thank you so much. It has been very fruitful listening to all of you. So I don't want to try to even summarize everything, but it comes very nicely together on some specific things. And what I have put on my sort of notebook, which we have not reflected so much on before, which is really, I think, focus on what many of you are saying, is education of healthcare workers, healthcare professionals, but also people living with and with lived experience, plus families and affected. This is really something very core that many of you have said, both on the partnership side, but also the implementation. And I think for the next 2 coming days, you could support us in thinking what kind of partnership could this look like. I was immediately thinking, of course, on my colleague, Jim Carrington, who is leading on the health workforce. We have developed competency framework for community-based workers in rehabilitation. Maybe this is something we could think of. But it also leads me to think about, as we mentioned earlier today, how can we really scale up and use digital platforms to really amplify education and disseminate knowledge? Also taking into account what you were very carefully saying all the time, namely cultural differences, and you emphasize a lot on language, which is very important take-home message from you, I think. And also, you didn't say these words, but health literacy and self-care would also be sort of natural thing to explore. That is also a way to scale up. That is also a way to pay respect. What is very different from this consultation from the other consultations, and that is really interesting to me, is that several of you have said, please bring type 1, type 2 together, especially when it comes to community level and the healthcare that is communality for these two groups. And please try to avoid stigma the one way or the other. And it seems to me that you're telling us that type 2 is more stigmatized than type 1. I have heard the opposite as well. Sometimes people say the pure sort of distribution of insulin is very stigmatized, while others are saying type 2 is stigmatized because of the lifestyle diseases it is associated with. I hope we can explore this a little bit in the days to come to go a little bit deeper on this. When it comes to accountability, I think you ask the right questions. How do we, in my sort of reading, it will be how do we develop an accountability framework for the compact itself? Because you will see when all of this come together, of course, you understand it's a lot of different roles. WHO support governments. Governments has to take up the work and be held accountable, but also different partners. If we, for example, have a partnership with the educational sector, they will also be held accountable. If your NGOs is taking on different things, that's also an accountability. So an accountability net framework has to sort of take into account the different roles and responsibilities, although, of course, in the end of the day, it is the government that is accountable for population-based protection and health measures. So there are, of course, different things, but I think this is also very good sort of discussions, and we need to continue. I see one challenge, and I'm Norwegian, so I speak very bluntly on things because I think this is the only way to get some understanding. And you actually raise it yourself as well, because the world, our world, the UN world, is very much sort of based on organizations as the entity. So when you look at the framework on how to engage as WHO with the world, we don't sort of engage with individuals, we engage with organizations. Sometimes we invite individuals, but we don't have a system to engage with individuals unless we have them as staff consultants and so on. And on this, I don't have the real answer yet. And on this is also important that Guy and Jack and GNP will continue to develop a framework on an engagement model on people living with. So I think we just have to be very honest that we don't see always how we can do this. So I think the best we can do just now is that I, as responsible for this, will commit to that I will do my ever best, and we will together try to find ways to include. I can make an example. You will soon see, maybe it's already there, a call for interest to become a member of a technical advisory group. And of course, the natural way that these things are put is towards, expertise, formal expertise, and so on. But of course, it's possible to combine, and maybe it's even possible to ask for lived experience as a certain expertise. I cannot actually give you the answer today, but we will definitely be able to sort of put it as a additional requirements, not necessarily the only, but an additional. So on this, I'm very open with you because I think this is something we need to do together. And I like the idea of an SOP. I want to challenge you back on one more thing, because I think it was, well, I don't remember who said that first, but one thing, if you think about the governance of the Global Diabetes Compact, that's a very sort of small thing. What I want is that you're part of the decision making where the real thing is happening, meaning implementation in the communities in the countries, in the region, in the sub-regions. So we have governance which is much wider than only to run this program. To run this program, we can put together steering committees and we can invite you, and you have to find out how we can find out who should come. But I think the much more important thing, where the co-creation of solutions will actually happen even more, is in Ghana or Ethiopia or Norway, for that sake. So I think from today, I am super inspired, and I think we got some real good advice, but also challenges back to WHO, which we didn't take into account. So already now, it has been very rewarding for me. But we also have some joint challenges, and that is, how do we find the best way, and how can we, because we cannot advise every country or every community in the world. So the way we as WHO have to work is through frameworks, guidance, messaging, and then it's very often the regions and the countries themselves that has to translate, both culturally translate, but also, of course, translate language-wise. So instead of just giving answers, and you actually asked me to feedback and reflect, I've done that, and I haven't really given you, or I haven't picked up on all the things you said, because I had like 2 pages dawdled down here. But this was what really sort of stuck out as the most important for me today. And I think when we look on all the slides, we will probably find even more granularity. So I would like to thank you, and over to the chairs.
Thank you so much, Dr. Bente Mikkelsen, for that reflection from the perspective of the WHO on the feedback for today's meeting. It has been a very successful meeting. So much to say. At this point, I would like to call upon our keynote listener to give us their reflections of the discussions of today. That is Nupa Lauvani from Health India Alliance. Over to you, Nupa.
Thank you, Heather. Hello, everyone. My name is Nupur, and I'm from India. I represent the Healthy India Alliance and the Blue Circle Diabetes Foundation. And I would like to firstly begin by thanking the WHO for creating this platform and inviting all of us here today. I think it's a historic day, and I think we're going to do great things together. The one thing that struck me was that while it's important for all of us to have a voice and have a platform, just like this one today, it's also very important to listen. And with that, I think I'm really honored to be here today as a keynote listener. And in the next 4 minutes, I'm going to try and summarize a little bit about what was discussed today. So here goes. Well, I think firstly, like, a couple of y'all mentioned in the comments, a really, really big shout out to Heather and Bruno. I think y'all had a great task, and I think y'all did a wonderful job being co-chairs today. So, shout out for that. And the one I'm going to quickly pick on, little things that struck me from each person's, talks. With Bruno, I think I think everyone will agree with me. We're not patients, but we're impatient for care. I think that was wonderful, Bruno. I think really really well put. And when Dr. Bente Mikkelsen, shared her thoughts, and she mentioned that this is not just a generic engagement. It's not just, a tokenistic activity of inviting people to the table, but it's actually a long-term plan. It's not just, to check something off a checklist or a to-do list. And I think we feel this today. We know it to be true, and we do know that people's lived experiences and our personal narratives are really driving factors in everything in our lives, but also in everything else. And then I'd like to move on to, what Dr. Guy Phones talked about, the 7 points that he mentioned. I think they were really, really brief and I think really important key points that he listed down. He spoke about meaningful engagement and he spoke about walking the talk, which I think is a big thing. I mean, a lot of us, we know each other through social media. We've interacted with each other on different platforms. We meet for a couple of days and then we go back to our normal life and things are, back to the same. I think it's very important, and I think it's a great step by the WHO to invite us here today and to start this whole thing where we can start walking the talk together. And I think it's important that actions reflect what we've spoken about and what we've decided we'll do. I'm going to summarize what Joab said now. And I really liked what he said when he said it's not just important to get people to the table after the food is on the table. I like that reference there. It's important to engage with people living with diabetes from the beginning, not just at the end, and not just before you have to not just before something gets rolled out. I think it's really, really important, and I think this is why I was going through the concept note that Jack shared, and I see that there is a plan. It goes all the way to 2023, 2025, and I think what we've started today is something that's very important, and hopefully we'll all see it through together. Moving on to the conversation that Apurva and Tiara had. I mean, great job, ladies. Y'all did. You really, really summarized a lot of our experiences. Apurva is a person with type 1 diabetes, just like me, and her mentioning that we need to collaborate, co-create, and hold each other accountable. I think that's also very important, very important point to note. Tiara, well, what I really loved, I think the thing that I really took away was that you want to be of service. And I think that's the core of what we do. As people living with diabetes, we have jobs, we have careers, we have other things going on, but this is something that we feel passionately about. We may not be medical experts, we may not be public health experts. We are people living with diabetes, and I think that's come up time and again in the chat box as well. And I think the very fact that we have lived experience is a very powerful thing. And I have to admit, at times I felt a little guilty about is it enough? Is just being a person with diabetes enough to have a seat at the table? Do I really deserve to be here? But yes, I do, and yes, all of us do. So I think that was a really powerful point. And a couple of other things that she mentioned about having full-blown diabetes. We see a lot of that here in India. We see the stigma around type 2 diabetes as well. Okay, moving on to David. I think really wonderful, and lots to learn from HIV and AIDS as well. And I think that we can't go around making the same mistakes. We have to learn from our peers, from our colleagues around the world, from our friends, and I think that's what we are doing today. So that's a wonderful, wonderful effort. Coming to Elizabeth, I think the key word that stands out with Elizabeth is transparency, and what she's doing at T1 International, I think, is a really wonderful job, and the whole team there. So I think that's something to learn for all of us, especially people that are starting out now and people that need hand-holding and guidance. I think we're all here in this together, and we're going to support each other. I'm not going to get into what each of the breakout rooms discuss because that's already been covered, but thank you once again. And Heather, back to you.
Heather, we can't hear you.
Thank you so much.
Heather, we can't hear you. I think finally your connection probably is caving.
So in this case, I would.
Thank you very much. I hope you can hear me now.
Not really.
I would like to hand over to Alexis, please.
So thank you, Heather. And so I'll jump in, and maybe you'll be able to connect as soon as possible. So yeah, so I'll try to speak, and then if you're able to connect later, you could share your thoughts. So on behalf of Heather and the whole attendees, I would like to thank every and each of you who stayed and remained with us despite our delay. I must say that the delay was not caused by technical issues, but was caused because of the love, the passion, and the meaningful involvement that our diabetes community have. I think we are all here to support each other and to be able to raise our voices for those that are not fortunate enough to be here today. So I'm really excited and looking forward for the next 2 days, and mainly looking forward for the next steps of the Global Compact. And once again, I must acknowledge the WHO and especially GCM and the NCD department for opening and for creating this space of sharing, learning, and co-creating. I must say that we are happy and we are confident that this is the first step of many, but be sure that very kindly and respectfully will be right after your backs to make sure this is not the last step of many that should be taken. So Alina, Jack, over to you, and thank you very much to all the attendees again.
Great, thank you so much, Bruno, and thank you everyone for your amazing participation. I'm in awe of so many people still on the line despite us running over a lot. We'll make sure that tomorrow we'll stick to time a lot better, as I am aware that we all have other obligations, but I just think, as Bruno said, it speaks to the excitement in the room, and we really didn't want to cut anyone off too early, even though we had to. So promise from our side that we'll manage time much better tomorrow. But a really exciting day. I think it sets us up really nicely for the 2 days to come, where we drill down a lot deeper into the details, the concrete opportunities of engagement, and we really look forward to your active participation. Jack, I'll hand over to you for some last comments.
No, thank you so much, Lena. Thank you everyone again for staying. Again, we're still very deeply humbled by a great engagement in the first day. I think we've been listening. I think we've definitely all been learning from the WHO side. I think that's definitely reflected in Bente's responses to the first breakout session. I'm sure that we'll continue to learn over day 2 and day 3, and this is really a great start to the consultation, and that's really been down to all those who have been contributing within the first day. So it's incredibly exciting. It's very exciting to see those responses from Bente, to see what those next steps are. Again, feeding back from the plenary, but also there's a lot of alignment from what was discussed in the breakout session 1 with the consultation in December with people living with NCD. So that's really promising to see, and I'm sure that will continue to build over the next 2 days. The last logistics thing for myself, we will solve the breakout session issue. So hopefully we'll not have any hiccups tomorrow. And we'll see you tomorrow at 1 o'clock Geneva time. So if nobody else has any other comments, I think we're good to close for day 1.
Thank you.
Thank you all. Have a good day.
Thanks a lot from my end as well. Fantastic shares.
Thank you, everyone. See you tomorrow.
Bye-bye.
Thank you, everyone. Cheers. Bye.
Bye-bye.
Bye. Bye, everyone.